We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, ART, organized by the Benchmark Series, Episode 12. So it's my privilege to introduce the convener of today's webinar, Dr. Neelam Desai, ma'am. Ma'am is the senior gynecologist and IVF expert. And ma'am is currently the director of ACME Hospital, Mumbai. And ma'am is ex-assistant professor, KEM Hospital, Mumbai. And ma'am has so many accolades to her credit. I welcome you, ma'am, and I hand over the session to you, ma'am.
Thank you so much, Sahiti. And it is my honor and privilege to be a convener for all our esteemed stalwarts in Dr. Sneha Boyar Madam's this academic
Ma'am, your voice is low, ma'am.
Yeah. Can you hear me now?
Yes,
Yes,
better, ma'am.
I can hear you now.
So I will take this opportunity to introduce our two program directors, Dr. Sneha Boyar Madam and Dr. Rohan Palshetkar. So Dr. Sneha Boyar, she has already held so many posts in Foxy and various organizations. She is practicing since 32 years into the field of obstetric gynecology, and she has made a mark for city of Yavatmal in our whole AMOGs and Pan India. And she is a proud Foxian, and she has vast experience of social work as well as clinical work and as well as high risk obstetrics practice. And we really look forward to have such clinicians in our leadership to progress ahead. Our next director is Dr. Rohan Palshetkar. He is phenomenal. He is the excellent leader. He has been heading Bloom IVF units across, and along with that, he has been a very core member to join all our ISAR candidates and ISAR. The people who are trying to come into the leadership are learning to be how to be leader, and he has been a phenomenal guide to a lot of people, and I really salute to his very noble work he's doing in the field. And both of you, please introduce the next speaker. Madam, please start with the preamble, and we'll start with our lectures. Our first speaker is Dr. Rohan Palshetkar.
Yeah, you have already introduced Rohan. Rohan, can we request you to say a few words?
Absolutely, ma'am.
Yeah.
Firstly, I think this is a fantastic series, the Benchmark series. It's been covering such essential topics, and this is the brainchild of Sneha Buyar, ma'am. Madam, you've always been such a great mentor to me as well. It's been amazing to be working under you and now with you as well in Foxy. It's been a great pleasure. And ma'am, I wish you all the best for your elections as well. I know it's coming up, so we wish you all the best, and I hope you pass with flying colors.
Thank you. Thank you so much. So a very good evening
to Dr. Rishikesh Pai will be joining after half hour. He is in some podcast, so he will be joining after half hour.
Okay. So I think a very good evening to one and all. My respect and regards to all the stalwarts here, especially our today's chief guest and our inspirations, respected Dr. Rishikesh Pai sir and Madam Nandita Palshetkar, and of course, respected Dr. Amit Patki sir, who is the National President of ISHRA. Our guest of honor, dear friends, Dr. Vinita Singh and Dr. Kalyan Barmade, the National President of IHE, Dr. Rohan Palshetkar, who has meticulously designed this program and involved all the young Turks who will be speaking on ovarian regeneration. Of course, Dr. Neelam, my dear friend, as convener, Dr. Ritu Hinduja, who will be speaking on PGT in today's era. Dr. Chaitanya will be speaking on RPL, and Dr. Shrutika Thakkar will be speaking on fertility preservation. I'm privileged to welcome the senior experienced chairpersons, Dr. Sharmila Yavu, Dr. Shamal Seth, Dr. Vinita Singh, Dr. B. Kalpana, of course, who is the Foxy chairperson of Infertility Committee, Dr. Yukti Vadhavan, Dr. Paresh Kandicha, who is a senior practicing infertilogist from Yavatmal, Dr. Nilesh Balkode, Dr. Preeti Vas, and a young boy, Dr. Anit Kumar. I welcome everyone and invite all of you for lamp lightning first. And then, of course, we will have first the blessings of God Almighty, and then we'll have blessings from our respected chief guest. So, Sahiti, yeah, can we have the inauguration video, please?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Yes, so Dr. Rishikesh Pai sir is yet to join. We would like to introduce our chief guest, Dr. Amit Patki sir, and would like to have his blessings. So all of you know sir as the National President of ISAR and Medical Director of Fertility Associate Mumbai, and of course he's the Honorary Professor KJ Somaya Medical College and Hospital, Consultant Khar Hinduja and Surya Hospital, Khar, Mumbai. He's the country representative for Aspire from the year 21 to 23, governing council member ICOG in 2012 to 21, such a long period. And so you have so many accolades to your credit, lots of publications and research to your credit. We are privileged to have you as chief guest, and so over to you for words of guidance from your side. Thank you for accepting our invitation.
A very good evening to you all. And at the onset, I must congratulate Dr. Sneha Buhar and Dr. Rohan Palshetkar for an excellent benchmark series. I think it sets a benchmark not only for them, but for all the other educational webinars and platforms that are going on. I have been part of the inaugural episode, and I've keenly watched how the episodes have evolved. And today the episode is on ART, which is a very, very trending topic, not only among the undergraduates and postgraduates, but also among the practicing clinicians. I can see a illustrious list of participants and faculty, and I'm so happy that Dr. Neelam Bise is going to lead this episode. So congratulations and my best wishes, and a special best wishes to Dr. Sneha for her elections and for all her future endeavors. So without wasting much time, I would like to congratulate and acknowledge and ask you all to take the proceedings ahead. Thank you.
So our first, I think we are waiting for Dr. Nandita Palshetkar madam also to join in half hour's time. Both of and
Ma'am,
we are
your
not able
voice
to
is
yet
very low,
connect.
ma'am.
We are not yet able to connect with Dr. Kalyan Barambe sir and Dr. Vinita Singh, but we will keenly wait for their honor. And it is very great to receive an encouragement from Dr. Amit Patki sir. Thank you so much. So we will move on to the next talk. I think we should start with the introduction of chairperson.
Dr. Vinita is having some problem in joining, but she will join soon. I think we can start with the academic session soon. And
so we will start with our chairpersons, inviting chairpersons. Dr. Shamal Seth sir. He is Vice President Foxy. He is consultant practicing in Kolkata. He has held many posts, and he is a very senior gynecologist, and he is a medical legal advisor also. Our next chairperson is Dr. Yukti Wadhwan. It is an honor to have Dr. Shamal Seth sir and interact with you. This is my first time when I'm interacting with you. Dr. Yukti Wadhwan, she is also holding a lot of posts, and she has many publications. She is the Secretary Delhi Gynecology Forum West for 23-25, and she has a lot of credentials to her. She is a co-chairperson for Midlife Club of the Delhi Gynecology Forum, and a lot of academic activities and social activities she keeps doing. So these two chairpersons, please introduce to Dr. Rohan Palshetkar, and we will move on to the topic.
Thank you, Dr. Neelam, for this opportunity to interact with you. Thank you very much. No, thank you, Sneha, for inviting me to chair this session. And infertility is still one of the largest branch of the gynecological aspect of our day-to-day practices, apart from the uh, endoscopic surgery, general gynecologist, and obstetrics. The other aspect, which is big one, is infertility. No doubt about that. And you are carrying on the series on this subject. And no wonder all the stalwarts are over here. Those who are famous for dealing the fertility issues are here, like Rishikesh, like Nandita, Amit Bhai, and the young one, the budding one, our own Rohan. I invite Rohan to speak on ovarian rejuvenation. And you all know Rohan. I don't think he needs any further introduction from any one of us. And better we should listen to him what he says about ovarian rejuvenation. Rohan, we are waiting to hear you.
Thank you so much, sir. It's always really kind to hear from you. You're always having encouraging words, and it's really lovely to always interact with you, sir. I will begin with my talk, but just before I begin, I forgot to thank Dr. Neelam Bhise. She has convened this program very beautifully as well. Thank you, Neelam, for being such an integral part of this program. I got carried away congratulating Sneha ma'am. I forgot to thank you at the start. So please excuse me for that. I am just going to turn on my presentation. Am I audible still? My
Yes,
Zoom,
yes,
my
very
Zoom
much.
just disappeared.
Yes,
Sorry.
Rohan.
Okay.
One thing, Sneha, before Rohan starts, actually, maybe after 10 to 15 minutes, I will be in an area where the network might be poor. So the concluding remarks should be given by Dr. Yukti, if I am not there.
Are my slides visible?
Yes. Not
Oh.
yet, Rohan, not yet.
Yes, sir. Now we can see.
Okay, fine. Perfect.
We can see.
Yeah.
Yes, now.
So today's topic, I'm going to be talking about rejuvenating the ovaries. I think this is a topic which is of major concern to all gynecologists, because the main issue, what ends up happening, is that when we have a poor ovarian reserve, whether it's a young patient or an old patient, our major concern is that uh, we want to try and give them a baby with their own eggs and try and avoid a donor egg cycle. So the best way to do that is to try and rejuvenate those ovaries so that we can get a good response. So what are the current trends? People are focusing on their career, there's late marriage, they're postponing pregnancy, and the biggest problem is they come in very late for a consult, where we end up getting stuck with a situation where there is a very poor reserve, and this all causes an increase in the infertility rates. Even today, when we look at the infertility rates, it's gone up from 10% to almost 17 to 18%. So we're talking about from 1 in 10 to 1 in 6 couples that are facing infertility. So we know that this is on the rise, and now it's a disease. It's no longer just classified by itself. So infertility affected by age, obviously, we do know that about 15 to 20% of all the couples, they're going to experience difficulties with conception. But this increases up to 50% when the age increases up to 38 to 40. So that's another thing. Now, how old is too old? See, what this entire slide is saying is that your ovarian aging starts in utero itself. In fact, as soon as you're born, you have 2 million. By the time you hit puberty, you have only 500,000. And by the time you're near menopause, you have less than 5,000 eggs beginning. I'm sure all of you all are very familiar with this slide. I think this has been something that's being used from back in the early 90s, I would say, when infertility started this, where we look at the optimal fertility between the age of 20 to 30, and then the fertility begins to decline. It's not just that, but it's also the quality. Now, if we look at what are the causes, we know that there can be genetic causes. Smoking, I think that's been spoken about since a lot of years, multiple decades, I would say. Adhesions, endometriosis, they can all lead to poor responders, where we get very few oocytes. So what are these poor responders? We had the Bologna criteria earlier. Now we have the Poseidon group 1, group 2, group 3, group 4. You can read all of these, but just to simplify it, what does this mean? It means that group 1 is a young patient with a normal reserve but with a poor response. Group 2 is an older patient with a normal ovarian reserve but a poor response. Group 3 is a young patient with a poor ovarian reserve, and group 4 is a older patient with a poor ovarian reserve. Generally, our biggest concern are these group 3 and group 4 patients because they tend to be of a poor prognosis. Now let's talk about rejuvenating the ovaries. So how do you improve the ovarian reserve? How do you rejuvenate these ovaries? One is either you use your adjuvants, 2, in vitro activation, PRP, and stem cells. So when we look at adjuvants, I think the slide is something that really resonates with me, that when adjuvants are there, the data around them is quite challenging. We need to figure out what works and what doesn't. So DHEA, again, has been used since, honestly, I think even the 80s, and it's something that's been there. Testosterone is something that's, I wouldn't say new in the market, but something that's still in its young age. It's not yet even an adolescent, I would say, in terms of using it. But how does it work? Now, DHEA and testosterone, unfortunately, the mechanism is still uncertain. It's been speculated that it increases the serum concentration of IGF-1, which possibly improves the response to gonadotropins. It improves the steroidogenesis. It acts as a precursor for estradiol and testosterone. It creates a PCOS-like characteristic and increases LH. This helps with the maturity, hormone follicular testosterone. It also reduces the age-related aneuploidy, and it's said to even increase the small antral follicles and AMH levels as well, which I still think is not possible, but it does at least improve the quality of the oocytes. So what does the data say? So this data has said that DHEA per se has no effect on improving the success, but testosterone improves the chances of a successful pregnancy in poor ovarian reserve. However, there's still a research is required on how long to give it. Generally, I give about 12.5 milligrams per day. It comes as a pump. So you take one actuation, you put it either on the underside of the arm or inner side of the thigh. But that way, theoretically speaking, testosterone can cause increased hair growth, but honestly, I've not seen it practically at all. I give about 12.5 milligrams. Generally, one actuation is 12.5 milligrams, and that is to be given for a month in the cycle prior to your stimulation, not in that stimulation cycle. There are certain papers which have said you can even give it for 2 months prior. So that's where the research is required to decide what would be the optimal duration of it. Melatonin, again, one of my favorite drugs to use. Melatonin, I know it's a drug that we think usually towards patients who are traveling from abroad for jet lag and this, but here we're not using 5 mg or 10 mg. Here we're using 3 milligrams. It basically acts like a scavenger, reducing the oxidative stress and therefore improving the oocyte quality. Coenzyme Q10, I think that's again another drug which has been making a lot of noise over the last few years. It basically acts as a mitochondrial energizer, and it also acts like a scavenger for reactive oxygen species as well. Now, basically, Casper has been someone who's been working on coenzyme Q10 quite a lot. What he has said that it basically, the reproductive system is like a forgotten flashlight at the top of the shelf. The thing is, it's there, but the batteries are not working. Just if you replace the batteries, the flashlight would work again. So similarly, there's nothing wrong with the eggs. It just needs another rejuvenation. That's what we'll go to look at. If you see this, ovaries age faster nearly than any other tissue in the body. And that's why we end up having menopause as a situation. So can we actually reset these sleeping beauties by targeting the mitochondria and chromosomes? Well, Casper presented a study in 2009 and 2010. What he saw was coenzyme Q10 actually made a big difference. If you see this picture on the right of the mouse ovaries, you see this left ovary which is there, which is the young ovary. The older ovary, you can see less follicles. When you give coenzyme Q10 and see the ovary, you can see the rejuvenated ovaries. Similarly, this paper published in 2020 said that coenzyme Q10 in poor ovarian reserve patients has the lowest cancellation rate in an IVF cycle and the highest clinical pregnancy rate as well. What he said, this was another paper which was published by Humaydan. He said that coenzyme Q10 had better quality day 3 embryos and less fragmentation of the cytoplasm as well. This meta-analysis published in 2024 actually studied all these different antioxidants that we use, the entire masalas, as we say. They saw that there's no difference in the live birth rate, but coenzyme Q10 and melatonin were the only two antioxidants which actually improve the embryo quality, and coenzyme Q10 actually increase the clinical pregnancy rates as well as the number of oocytes retrieved. So generally with coenzyme Q10, I like to give around 300 milligrams twice a day, and that really helps. With in vitro activation, this is something that's coming up new. There used to be there's IVA where basically you take out a piece of the cortex, you put it in a P10 inhibitor and a PIK3 enhancer, and that rejuvenates the cortex and you reimplant it. This is generally done in two-step surgery where it would be done 48 hours later, the regrafting. However, now you've got a drug-free IVA which has gained popularity, where in one sitting itself, you can remove and reimplant the cortex immediately after an hour, and this basically improves the response and improves the ovarian reserve as well. So this is the video of how it's actually done. So what you do is you go in endoscopically and you cut a piece of the cortex. Once the cortex part is removed that you want to rejuvenate, then you take it in the lab, you cut it. I have not done this process myself, but you cut it into 1 millimeter cubes. All right. After you do that, you can actually then, while this is happening, what you should do is you should start creating the pockets in the ovary, so where you can reimplant these grafts. This is happening simultaneously while this is going on. Once it's there, then what you do is you use the applicator and you reimplant the cortex back into it, back into the ovaries or into the pockets that you've created. Once that is done, then you can just apply your adhesion barriers on the areas which you have done, and that will help in ensuring that. See, as far as possible, we would like not to use any cautery because we're going to try and reduce the ovarian, that would reduce the ovarian reserve further. Then PRP is something that's being used. Scott Sills was the one who actually published the first paper in 2018, where he injected 5 ml of PRP into each ovary of a menopausal patient, and he still got a blastocyst from each of them. This paper actually got intraovarian PRP into the limelight, and that's when people started talking about it. You can see all the factors that actually how they would improve the ovarian reserve. So you can do this in two manners. One is transvaginally, the other one is this. Sorry. The other one transvaginally, and the other one is you can do it laparoscopically. I'll show you the laparoscopy as well. So generally what you end up doing is, it's like how when you're doing a pickup, you do a scan. Through the scan, what you do is you insert the OPU needle inside, you go near the cortex and inject the PRP. I know Scott still said 5 ml. Trust me, I've done a lot of PRPs. Being very honest, it's not easy to inject 5 ml. You can inject about 2 to 3 ml. In fact, now sometimes what happens is the ovaries can be very small. So because of that, if the ovaries are small, then in that situation, what you can do is you can give the patients letrozole, have a follicle grow so the ovaries are easily visible, and then you can inject the PRP into the ovaries. This is laparoscopically. Generally, it's advisable to do it sonographically, unless there is some other thing that you need to check through your laparoscopy. Then what I do is I don't use this needle anymore. This was one of my first few surgeries. What I do is I take the pickup needle and insert it into the abdomen like how we would do an ascitic tap, and you inject about 2 to 3 ml into the ovary itself, and that is there. What you do is, in case there's bleeding from the ovary, once you do it, generally with the OPU needle, it doesn't cause any bleeding. It can with the vasopressin needle that we do use. In case there's bleeding, don't get tempted and use cautery. What you do is insert a gauze piece through the 10 mm port and just give pressure on that ovary for about 5 to 6 minutes. The bleeding will stop on its own itself. If you look at PRP data, here you see in the highest AMH increase 3rd month post. Yes, that's another thing that you need to understand, that once you inject PRP, do your stimulation 3 months later. Don't do it earlier because you may not get a response. what PRP has said, at least it will improve the oocyte quality. There's a spontaneous pregnancy rate of 7%. In fact, I've had 2 natural conceptions with PRP, because in the 3-month period, they just got pregnant naturally. If you see the clinical pregnancy rates, it's 18% and live birth rate is 11%. But these are patients who would have probably required an oocyte donor. So imagine if you're able to give them, you've taken them from a 0% chance of their own eggs giving them a pregnancy to at least 18 to 11%. Generally, there are no complications associated with the procedure if you are very clear with where you've injected, and it's usually has very few risks involved. PRP preparation, every lab is going to have a different PRP preparation. There are multiple preparations which you can get off the internet, or if you're getting your PRP done from outside, that is also fine. In fact, I feel that if you have any dermatologist friends, they do a lot of PRP. You can speak to them also and understand what would be one of the ideal ways to prepare PRP as well if you're not doing it yourself. This is another paper which was published in Jan 2025. Over here, what they saw was that with they used the same patient prior. When they were using it prior, they were the control, and when you're using it after injecting PRP, they were in the study. So ideally, they were the same patient who did a stimulation prior to PRP and then post PRP. So what it is said is group 2, basically the ones after PRP, when they did the stimulation 2 months after, they got more number of oocytes, more blastocysts, top quality blastocysts after giving the PRP. Now, stem cell therapy, again, it's under a lot of research and there still needs to be done. Again, I have not done any stem cells myself, but Dr. Nandita and Dr. Rishikesh Pai have done a lot of stem cell cases. So when they do join in, we can maybe just ask them a couple of questions on it. But there have been stem cell pregnancies as well in India. So that's fantastic that it is, but it's still in its nascent phase, and it does require a little bit of more research before we can consider it to be a part of everyday treatment. It has to be explained as an experimental treatment and not as a regular, because it does require bone marrow, autologous bone marrow derived stem cells. So that's how you end up using it. The studies, this was a meta-analysis published in 2024. There were just 5 studies with 153 patients, and they show potential for restoring ovarian function. However, there's a lot of heterogeneity in these studies. So therefore, it needs to be taken with a bit of pinch of salt about how successful will it be. Regarding PRP, regarding stem cells, I always tell them that only a 20% chance that this may work. So to just conclude my talk, I wanted to say that POR is a challenge for every gynecologist, whether you've just gotten into practice or whether you've been in practice for over 30 years, it's still a challenge for everyone. However, adjuvants currently, they have an unclear role, but they don't seem to have any side effects. So feel free to use them. I feel a combination of DHEA or testosterone with coenzyme Q10 with melatonin works beautifully well. There are other things as well which can be used and they also work excellent, but these are things which I use in my practice. There are various technologies that are available. I think it's important that we discuss them with our patients and eventually give them all the information there is, and then they can take a decision on whether to go for it or not. We must give all the options. We should not just think about doing a donor oocyte directly. Right now, even with the mitochondrial transfer, which has given a baby in the UK, maybe once it gets more established, we may be able to give patients their own nucleus, because the mitochondria re-energizes. So the future does look promising, and I genuinely hope that in the future we're able to give every woman a pregnancy with her own eggs and maybe not require donor oocytes at all. So thank you very much for a patient hearing, and I hope I was able to give you a good take-home messages with all the talks about rejuvenating the ovaries. Thank you very much.
Dr. Dr. Rohan, it's nice talk. We can see Dr. Kalyan Barande sir is also joined. Welcome, sir. Sneha madam, can you take an honor to talk about Dr. Kalyan Barande? Then we can ask for the remark from the chairperson.
Yeah, we welcome Dr. Kalyan Barande, a very dear friend, my younger brother, and we are so proud to have you. You know, Dr. Kalyan is the national president for IAG. We're really very proud of you, Kalyan. He was the secretary of IAGA. Of course, he has climbed up the ladder. So I
Thank you, ma'am.
did that. And of course, he was a co-chair with me as Public Awareness Committee chairperson, and lots of awards and accolades to his credit. A man of substance, I would say. We are very eager to listen to your precious words, Kalyan. So over to you.
Thank you, ma'am. It was a nice lecture by none other than Big Palshikar. And here I'd like to
Kalyan sir, your voice is
congratulate Dr. Sneha ma'am, Dr. Neelam Bise, and whole team for organizing subjects like Orient Regeneration, PGT. I'm just outside the OPD. Yeah. I am audible, ma'am?
yes, now you.
Am I audible?
Yes, Dr. Kalyan.
Yes, sir,
Yes,
you are.
please go ahead.
Yeah. So I'd like to wish all the best to my dear friend and elder sister, Dr. Sneha Buyar, for her upcoming elections. She's the most deserving person and has to be in the Foxy team. And I wish all the best. Please give her blessings in form of votes. She's the Foxy work.
Please unmute. Kalyan, please unmute. You got muted.
And this is a really good webinar where there are fertility treatment options has been talking about, and it's a good start by Dr. Rohan Palshetkar, and he has talked about one topic which is very dear to our heart, fertility preservation. And I wish all the best for this webinar and many, many good wishes to Dr. Sneha ma'am. Thank you so much.
Thank you. Thank you so much, Dr. Kalyan, and thank you especially for your sparing your precious time and joining the webinar. Thanks for your wishes.
Thank you, ma'am. Thank you so
Thank
much.
you. So I think
good news that Dr. Nandita Palshetkar madam is also joining just now. So
Yes.
the next lecture. If you
Kalyan sir, thank you so much for your kind words.
Dr.
Yeah.
Shamal sir, do you have some comments about Dr. Rohan's lecture?
yeah, I can see Madam Nandita Palshetkar joined just now. Madam,
Please go.
a very good evening and welcome.
Hi, good evening.
Madam, a very good evening to you and a warm welcome from our side. We are very happy and privileged to have you. I mean, it's always a pleasure to introduce you, Madam. I have worked under your leadership as a President Foxy, and you have actually handled and mentored us. We are whatever because of you today. So we are very privileged and blessed to have you, Madam. And we are really eager to listen to your precious words. All of us know you so well. I'll just say, name the organization, and Madam has headed it. Of course, she's got such a illustrious CV and highly decorated personality. So over to you, Madam Nandita Palshetkar, for your precious words. Madam, please unmute yourself. Nahi. Madam, please unmute. Saiti, is there some problem?
Yeah. Now I've managed it. I think first of all, thank you very much, Sneha, for inviting me. And it's a pleasure that you and Rohan are both program directors. I think both of you all are very close to my heart. And I'm really happy that this is ART. ART is something that I'm very passionate about, and I live, breathe, and eat ART. And I can see so many friends. I can see Kalyan grinning. I think Kalyan, God bless you.
Namaste.
You
Thank
know
you, ma'am.
what? I really do love you. And Neelam and Sharmila and who's this? Oh, Ritu. Hi. Sorry, I'm on this. Then who's this? Chaitanya. Wow, all my favorite people here. Rohan, I know you've switched off the video, but it's okay. Then who is this? Yukti is there. I think. Amazing. I think, IVF is very, very important right now. And I'm so glad that you've taken that topic occurs 15 to 17% incidence of infertility. And I think everybody needs to be tuned into it. And all the people that I see over here, yeah, Preeti, hi, that, those are all invested in IVF. I think Neelam, I don't know whether I mentioned your name, but welcome, Neelam. I think you've been calling and everything. So IVF is very, very important today's generation because the law has come and it has definitely streamlined a lot of practices, and it has there are people who don't know that there is a law which states you can put only 2 embryos in a person. Today morning I had a patient in the OPD where it was written first TT and 3 embryos put in. I think it's very important, Sneha, these kind of CMEs to be done so that people get to know about it. And I think, Charmila, you are in a position where you're connecting with people. I think it's very important. All the chairpersons, I think, it's important to connect and inform them about the law, because this is what happens when you are not aware of it. And it's a big center which has done this. So I think these kind of CMEs are very important. Spreading the knowledge is very important. And Sneha, I wish you all the best in your endeavors. Then Preeti, I think you're also going for it. And Charmila, next year.
No,
All the best.
2 more years, ma'am.
I think Rohan also next year. Kalyan has achieved it all. Kalyan, when
Yes.
are you becoming a minister? That is what I want to know.
तुमचा
I
आशीर्वाद
think-
ठेवा मॅडम.
Yeah, sorry, I think I've created Rohan. All the best for next year. It's next year, right?
No, 2 more years.
2 years, okay. So I'm too early with the all the best. But
We are all dreaming for you
but
to become.
Sneha,
Always
please,
great.
please see
Right.
that. I mean, all my best wishes are with you, and I love the
Need your
perseverance.
blessings and all your prayers also.
No, the perseverance and the way you go on conducting and educating people, I think it's very, very important and very, very essential. So, all the best and thank you. It's my honor to be here today. And I think IVF needs to spread to people. And I'm sure everybody, when they talks, they do talk about the law. I think it's very important to educate people what is to be done and what is not to be done. I think that is really, really important. So thank you very much for inviting me, Sneha. All the best and all the best to everyone. Thank you. Thank you.
Thank you. It's an honor, madam, for all of us. Thank you so much. Thank you for gracing the program and, of course, your precious words. Thank you so much. I think, Neelam, we can go ahead with the next session. Thank you so much.
Thank you.
We have myself as a chairperson for the next session and Dr. Charmila Ayyavu, madam. And it's an honor to be a co-chairperson with Dr.
Yeah, I think I
Charmila.
can introduce you, Neelam. Don't worry, I can
It's
introduce
fine, ma'am.
both of
I have
you.
already been introduced. Let's do Dr. Charmila.
Okay, so I will introduce Dr. Charmila, no worries. So Charmila is a very dear friend and of course a very illustrious personality, very academic, and of course she is the immediate past vice president of Foxy, and I'm sure we are looking at you to be there as a president of Foxy. She's the director of Aditya Hospital Parvati Ayyavu Fertility Center Trichy, and of course she has headed, she has headed many posts, and of course she's a very research oriented personality. She was a chairperson for Clinical Research Committee Foxy, and we are very happy to have you, Charmila. I think the session, Neelam is already introduced, so both of you do the honor to introduce the speaker and take the session ahead. Thank you so much.
Yeah. Thank you, Sneha. Neelam, can I introduce Ritu,
Yes,
or you
ma'am.
want? Yeah, thank you so much. It's an honor to introduce Ritu, who's one of the, I would say, the very erudite speaker, very, very clear in her thoughts always. And it's an honor to listen to you, Ritu. And on such a topic, which is quite controversial, I would say, like many centers still do not accept PGT as a mode of diagnosis and management. And if you would like to hear you talk on that, this CV is very, very small because you're quite elderly. Can you make it a little bigger, zoom it bigger?
Ma'am, it's okay. I think you speaking
ma'am.
about me and saying that my talks are good in itself is a very big introduction. So thank you so much, madam. Thank you.
You're eager to listen to your talk, Ritu. Please
Thank you,
carry.
ma'am.
Thank you so much.
I am unable to share.
Your screen is shared. You just open your PPT.
Can you see the share button, ma'am?
I can see the share button, but I just need to
Screen
go
is
to my
open.
PPT.
It is already shared. You just
Yeah.
open it.
Yeah, we can see the slides, ma'am.
Yeah.
Oh,
Thank you.
okay, yeah. So today we are talking about pre-implantation genetic screening for embryo selection. Okay, so now talking about what are the methods in which we can actually screen in a pregnancy. Once a pregnancy is established is of course ultrasound and hormonal assays. We can do that at 11 to 14 weeks. We can do an amniocentesis and chorionic villi sampling, which is done at 11 to 15 weeks. And there is NIPT, which we can do at 10 to 11 weeks of pregnancy. However, if there was a way to test before the woman got pregnant, wouldn't that be really good? And science had an answer for that. We have something in which we can test the embryos before we even transfer it into a mother and she can get pregnant, which is known as pre-implantation genetic testing, for which we need to do an IVF. So it is IVF plus pre-implantation genetic testing. And to be able to do something like this, what is most important is your preconceptional counseling. Without preconceptional counseling, going ahead and doing an IVF with pre-implantation genetic testing does not serve the purpose, because there are very clear indications for pre-implantation genetic testing, like if there is any kind of genetic disease that we can screen via the help of this testing, one of that, and the rest of the indications I will cover in my future slides. So there are three types of genetic testing, which is known as PGT-A, which is pre-implantation genetic testing for aneuploidy, PGT-M, which is pre-implantation genetic testing for monogenic diseases, and PGT-SR, which is pre-implantation genetic testing for structural rearrangements. Now, PGT-A is basically screening the embryos. It can be for advanced maternal age, recurrent implantation failure, recurrent pregnancy losses. However, PGT-M and PGT-SR used to be initially known as pre-implantation genetic diagnosis, and PGT-A used to be known as pre-implantation genetic screening. So that was PGS and PGD, but now they have been recoined. It's been quite some time, but I just want to make it very clear that there is a difference between screening and diagnosis. PGT-M and SR are for diagnosis. PGT-M diagnoses conditions like cystic fibrosis, BRCA, Huntington's disease, etc. PGT-SR, we can, test for chromosomal translocations or inversions. And PGT-A, of course, where we screen for the presence of all 46 chromosomes to identify embryos most likely to implant and result in a healthy pregnancy. But we can also screen them for Down syndrome, Klinefelter syndrome, etc. PGT-A basically came into clinical application in ART in 1990. It was first used to prevent X-linked diseases and X-linked mental retardation by a professor called Handyside et al. He was the first one who did pre-implantation genetic testing for aneuploidy. Soon after the above success, its widespread use in IVF was started. PGT-A was established to improve the reproductive outcomes in advanced maternal age and recurrent miscarriages. Now, pre-implantation genetic testing for aneuploidy is used for selecting chromosomally normal embryo, right? Okay. So why do we need to screen the embryo for chromosomal abnormalities? Because abnormal embryos don't implant or end up in an abnormal baby. And if you can see, abnormal embryos, as the age increases, the percentage of abnormal embryos also increases, right? Now, and because abnormal embryos increases the risk of miscarriage as well. So as the percentage of miscarriage increases as the age increases, and only morphological criteria fails to select the best embryo. Good morphology does not always mean good quality, and it has been proved time and again. So if you go to see this slide, if we had to transfer a good looking embryo, we would look at something with equal number of blastomeres, with less debris, and which looked like a good embryo. So if you go to see 1 looks good to me, 3 looks good to me, so I would probably morphologically try to transfer those embryos. However, when a pre-implantation genetic testing is done, if you can see 4, 5 and 8 came back as genetically normal embryos, and the rest that I was talking about with equal number of blastomeres, a good trophectoderm, and less amount of debris, those came back as abnormal. So the well-practiced indications that I was talking about are advanced maternal age, implantation failure, which is more than 2 failed or more failed IVF cycles, recurrent miscarriages, more than or equal to 2 miscarriages, severe male factor, that is low sperm count, and prior child with chromosomal abnormality. So abnormal embryos also increase with age. So the embryo screening should become a must. And now in ART law, of course, this is one of the indications where you can offer pre-implantation genetic testing. Please let me make it very clear that in the ART law, you cannot do pre-implantation genetic testing without a specified indication. So you have to justify why did you do pre-implantation genetic testing in a person if you have done it. The aim of PGTA is to decrease miscarriage rate and increase live birth rate. Selection of the euploid embryo for transfer increases the likelihood of pregnancy and thereby IVF success rates. Chromosomal aneuploidy is common in human gametes and pre-implantation embryos and is a major cause of IVF failure, miscarriage and stillbirth rate with an incidence at birth of less than 0.3%. The pre-testing expectations that you and me probably would have is the question to offer or not to offer. Now, this was a question that was maybe a bigger question before the ART law came in, but after the ART law came in, hello? Can you hear me?
Ritu, you carry on. You carry on.
So before the ART law came in, this was a bigger question, but now after the ART law has come in, it is very, very clear who can you offer pre-implantation genetic testing. I've already covered that, and who you cannot offer pre-implantation genetic testing. The general consensus is to offer PGTA to patients with advanced maternal age, recurrent implantation failure, recurrent pregnancy loss, or previous abnormal pregnancies. There is no consensus, however, for severe male factor infertility. So before you kind of offer it for that indication, you have to justify it, right? Now, of course, we have already spoken about that you have to do an IVF. Once an IVF is done and you've created the embryo, the biopsy of the embryo needs to be taken. Now, when you're counseling the patient and the patients come back and ask you, but our embryo is getting destroyed, it is very clear that the embryo does not get destroyed. So this is the inner cell mass. If you can look at my arrow, this creates the baby, right? And this part is the trophectoderm. This trophectoderm creates the placenta. What we do in the biopsy is we take few cells from the trophectoderm and not from the inner cell mass, and thereby it doesn't impact the baby per se. It is a safe procedure because all these cells, whether it is from whether it is a trophectoderm or whether it is in the inner cell mass, they all come and they are generating from the the initial cells, the same eggs and the same sperms. That's why the cells of the trophectoderm sometimes, not always, I'll talk about that in the future slides also, in most of the times reflect the chromosomal structure of the inner cell mass as well. So you create the embryos, you take the you send and you freeze these embryos. These embryos cannot be frozen 2 on 1 straw. You have to freeze 1 on 1 straw, because that is how the result will come, and you will be able to know that which of the embryo is normal, so that you can thaw that embryo only, and you're not touching the other embryo, because there can be 2 normal embryos. If you have frozen on 1 straw, then you will be thawing 2 normal embryos, and if the patient wants a single embryo transfer, you'll be wasting the other embryo. So every time that you are sending up embryo for pre-implantation genetic testing, please make sure that it is 1 embryo on 1 straw or 1 cryotop, sorry, and then the embryo transfer is generally done in a frozen embryo transfer cycle. So the technique of biopsy initially used to be a polar body biopsy, then we moved on to a cleavage stage biopsy, but now 99% of laboratories are doing blastocyst day 5 biopsy because our vitrification technique has increased, has improved, and it gives us a better success at thawing and reclaiming our embryos, right? Initially, day 3 biopsies used to be done because we used to get the report in the same cycle and it could offer us to transfer the embryo in the fresh cycle. However, now because of very strong vitrification programs in our laboratory, we are able to freeze and thaw the embryo without any harm on the embryo, right? Now coming again, I've already spoken about the pros and cons of the cleavage stage biopsy and the blastocyst biopsy. Now this is something that I want to show you, is that this is a cycle of a patient which was done without pre-implantation genetic testing for aneuploidy. So the first transfer we did, it was a negative. The second transfer was again positive. The third transfer was again negative. The fourth transfer was negative, and the fifth transfer was negative, and the sixth transfer was positive. Multiple attempts at transfer to get a pregnancy can be avoided if we do pre-implantation genetic testing, in which we can discard the embryos which do not have the potential to give us a pregnancy, because an abnormal embryo, like I said, nature takes care of itself and it will prevent an implantation, or it will land up in an early miscarriage. So we test them and we transfer, and we have a higher success rate of stumbling upon a pregnancy. Now coming to how many eggs does a person need to be able to do pre-implantation genetic testing, there is no magic number nowadays, because there are women who are attempting to get pregnant with their own eggs even at an age of 40 plus. I still advise them, even if they have 1 or 2 embryos, to go ahead and do pre-implantation genetic testing on the embryo because of their advanced maternal age. So as such, there is no magic number on the number of eggs that you can retrieve or you should retrieve, and the number of embryos you should gather before you send an embryo for pre-implantation genetic testing. However, every patient should be counseled that not all eggs will give you embryos, so they have to be told about the dynamics of eggs versus the day 5 embryos, and that we will lose embryos on the way. And that is also why I like doing, or everyone likes doing, a day 5 biopsy, because on day 3, if you're biopsying, say, 5 embryos, not all 5 will have the potential to go up to day 5. So you first check the potential of the embryos to reach a day 5 status, and only then take a biopsy of the day 5 embryos, right? Now, is there a magic number of oocytes? I've already answered that. However, there have been studies in the past where they say that the optimal oocyte yield seems to be 8 to 15 for younger patients and 16 to 20 for older ones. Why? Because older women will have more aneuploidic embryos. So it is better to have more number of eggs, which is again not possible because the ovarian reserve declines, the AMH declines. But however, this was the study which was done, and they said that if a woman is younger, you may get euploid embryos in just 8 to 15 eggs, but you may need a higher number of eggs in a woman who's of an advanced age to get a euploid embryo. You may need 16 to 20 eggs. It is like going to a bowling alley. You increase the number of oocytes, you increase the chances of stumbling onto a euploid embryo. So there were studies which said that the number of euploid embryos available for embryo transfer increases as the number of oocytes obtained does. And there were studies which said that if you increase the gonadotropin dose, then you increase the aneuploidy rate in the embryos. Those studies were then debunked, and that theory was dismissed, that a higher dose of gonadotropins does not increase the aneuploidy rate in your embryos. So you can be a little more you can stimulate harder if you are doing a pre-implantation genetic testing cycle to get more number of eggs, because increased number of eggs will lead to increased number of embryos, will increase your chances of stumbling onto a euploid embryo. So if you are producing lesser number of embryos in a cycle, there is a chance of pooling those embryos and then sending them for testing. What we generally do is we do multiple cycles. We create the embryos, take the biopsy, and you can freeze the biopsy and keep it with yourself. So you collect those biopsies and then send them for testing together, because that will be more cost effective rather than sending one biopsy for testing. So what you do is you do the cryo pooling, you do the embryo pooling, you do the biopsy pooling also, because you cannot thaw and then take a biopsy and then thaw, then freeze again and then thaw at the time of transfer. So you take the biopsy in a fresh embryo, you tube it and you keep it with yourself in the environment that comes with the instructions. You pool the biopsy and then you can send the biopsy together for testing. So again, like nothing remains the same. This is Dubai in 2009 and this is Dubai today. Everything evolves. Our techniques have also evolved. We have moved from polar biopsy and cleavage site biopsy to blastocyst biopsy. We have moved from fish to array CGS and next generation sequencing. Our blastocyst cultures and blastocyst formation rates have improved. Our vitrification program has got strengthened. And along with your pre-implantation genetic testing report, you also start getting mito scores. Mito scores are basically the score that they give you, that which embryo is should go inside first. So mitoscore 1 is the embryo that goes inside before any other embryo goes for transfer. So they give you the mitoscroll testing, and according to the mitoscore testing you can decide which embryo, even in an euploid embryo, you would like to transfer before you attempt the other euploid embryo. So if you have 3 euploid embryos and you have mitoscore 1, 2 and 3, you will transfer mitoscore 1 first in the first attempt. If you get a pregnancy, well and good. If you don't, then you will thaw the mitoscore 2 the next time around, and so on and so forth. So embryo biopsy again is an operator dependent outcome. Biopsy is a highly technical procedure. Not all are trained to do the procedure. Even though trained, there should be enough procedures in a laboratory to maintain that skill of the embryologist who is doing these biopsies. Before you attempt to do pre-implantation genetic testing and biopsy in your laboratory, you should know whether you have the right equipment, whether you have a good embryo system culture. You should have a skilled embryologist. They should have at least done 50 blastomeres for fixation and 100 cells for chromosomal analysis. This is an ESHRE PGD consortium guideline for pre-implantation testing, genetic testing. There should be training on sampling and tubing for successful placement into the PCR tubes. So the tubes are very small. You should know how to place the biopsy in the PCR tubes. The detectable DNA should be more than 90% in the embryo biopsy done by these embryologists which are getting trained. And there should be an optimal cryopreservation program, which is again vitrification. You should have a very strong program. So now coming to the selection of a genetic lab, the lab should be proficient in one of the PGT8 techniques, which is any one of them, but now everyone's doing next generation sequencing. It should be consistent and reliable. It should have a QA QC in place, and it should audit its own diagnostic and misdiagnostic rates. It should have less number of mosaic embryos being reported, and it should be validated and accredited. So now there is of course realization and consideration that you need to keep into perspective. There can be change in circumstances and scenarios which need to be considered. So if you have only 1 or 2 embryos available per biopsy, in this case a joint meeting should be done with the couple and the IVF specialist and the embryologist, depending upon the fertility background, for doing the pre-implantation genetic testing for aneuploidy. For example, if the woman has recurrent pregnancy loss in the past, it is a better option to proceed with the biopsy of one embryo also if you have only 1 embryo, to avoid further miscarriages. And in an advanced maternal age, if she's doing IVF for the first time with no other significant history, you can consider to proceed with the embryo transfer with a morphologically good grade blastocyst, as auto selection of the best embryo has already been done. So you can avoid doing pre-implantation genetic testing in that woman who doesn't have any past history. But if she has a past history of recurrent implantation failures or recurrent pregnancy losses, it's better to go ahead and test even if there is 1 embryo rather than not testing it. So this is an igenomics report that comes. So if you can see, there's a mitoscore 1, 2, 3, and this is just a random laboratory report that I have taken. Of course, whatever reports that you use, whichever laboratory that you use, you can ask for a mitoscore ranking so that you know that even in a normal embryo, which embryo needs to be transferred first can be decided by mitoscore testing. So post-testing consideration, you can have mosaic embryos. So which mosaic embryos to transfer and which not to transfer, there is a very beautiful chart. But before you decide to transfer any kind of mosaic embryo, there needs to be a pre-implantation genetic counseling which is documented on your file that you have explained to the patient. So if they have mosaic chromosome involved in 1, 3, 10, 12 and 19, there is very low risk of any adverse outcomes in the child and you can go ahead for transfer, but you need to document it that the patient has been counseled. And of course there is 13, 14, 16 and 18, 21 and 45 and X, which are best to be avoided if there is a mosaicism which is involving these chromosomes. So what do you mean by mosaic? We mean that if you've taken a biopsy, so the red part, the red cells are abnormal cells, the blue cells are normal cells. Sometimes, see, this is like a normal embryo. So if I take a biopsy from here, I'm going to get a report which is going to come back as normal. If I take a biopsy from here, it's going to come back as an abnormal. So this is okay because the inner cell mass and the trophectoderm have the same chromosomal constitution. But sometimes there can be a mixture of abnormal and normal cells. So if I take a biopsy from here, from a junction of a red cell and a blue cell, they may tell you that it is a mosaic embryo. It can be a normal mosaic or it could be a mosaic. Now, what do you mean by normal mosaic and mosaic? In a normal mosaic, that means the inner cell mass which creates the baby is normal, but the trophectoderm has some abnormal cells, which is normal mosaic because the inner cell mass is what is going to create the baby. Now mosaic will be where the trophectoderm and the inner cell mass have some abnormal cells which are interspread between the normal cells. So there is now a newer technology, now no more newer, but you can do with something which is known as non-invasive PGTA or it's only used for PGTA. So non-invasive PGTA is done by testing the embryo, the culture media in which the embryo is suspended. So the cell-free DNA which is spent in that culture media is then aspirated and sent for testing, and this is known as non-invasive pre-implantation genetic testing. There have been certain mishaps in not Indian laboratories, of course international laboratories, pertaining to non-invasive PGTA. So before you do non-invasive PGTA, make sure that the counseling is done, make sure that the patient understands that there can be an erroneous reporting, that the embryo which is reported as abnormal could be normal on an invasive pre-implantation genetic testing. So all that counseling needs to be done and documented in your file. Of course, there was another way where they could aspirate the blastocelic fluid. That means the fluid which was there in the blastocyst, they would aspirate it and send it for testing. I've never seen anyone do something like this. So of course, non-invasive is something that a lot of laboratories are doing. But if you do it, you need to have a proper consent available in your file. So is it worth it? Yes, it is worth it. Is it monetarily justified? Yes, it is monetarily justified, because you have to understand there is an attrition wrinkle which is there, because a woman who has done multiple IVF is not getting pregnant will drop out of doing an IVF cycle and she will go home without a baby. So rather than waiting for you to stumble upon a normal embryo in multiple attempts, if she's not conceived in 2 cycles and if you're going to do a fresh pickup, it is advisable that you offer pre-implantation genetic testing, because that will save her time of doing multiple transfers in the future. She will stumble upon an euploid embryo, take the transfer and have a higher success rate of taking the baby home. So the benefits of doing PGTA has evolved a great deal. It does benefit a lot in indicated cases. It allows single embryo transfer with a higher success rate. It reduces the financial burden of multiple IVFs, like I've already spoken about. It is no longer invasive, if invasive is what we are trying to avoid, and it is the way forward. So there is an ASRM committee opinion which says there's inefficient evidence which was recommended, but this was a 2018 opinion which is changed over years, and now it is a procedure which is recommended, which is justified, which is scientifically proven. So technology is not just a tool, it can give learners a voice that they may not have had, and PGTA is just that voice for your patient if she fits into that category. Thank you so much.
Thank you, Ritu. Very, very clear as always. But you were so convincing, I would say, because the ASRM committee opinion was very clear that it's still in research phase and I can't do for everybody. And we always have those doubts. Like for a younger patient, I can always accept she has got many embryos, she's got a prior history of a genetic problem in the family. You know what to see for. But for an older woman who's having repeated miscarriages or repeated implantation failures, who's having less embryos, and suppose you take that one embryo for a biopsy and it turns out to be, and you lose the embryo because of the biopsy, that is also sometimes very disheartening. So, but you are so convincing. So I just wanted to know, because we usually don't quote from personal experience, but what is your experience regarding PGTA? Where are the indications where you found it was very good for your patients?
So, ma'am, definitely in recurrent implantation failures and recurrent pregnancy losses, definitely. In advanced maternal age, ma'am, I do recommend it if the patient. So I have to recommend. I have to document it on the file, because what happens that sometimes, at least in a city like Mumbai, they come back and they question you that if it is a failure, that why was I not advised this test?
It's everywhere. It's not only in Mumbai.
So, ma'am, I would recommend it, and I have seen that in advanced maternal age, with the newer protocols that we have to stimulate women, and with cryopooling, we at least get one euploid embryo. So they have to be mentally prepared, they have to be financially prepared to do something which is known as cryopooling, and then send it for testing, because testing one embryo is not even financially a very smart decision, because it's going to cost her that much. So might as well pool those embryos, do multiple cycles, and then try to get one euploid embryo. I've generally stumbled upon in most of my advanced maternal age patients that I do get one at least euploid embryos. But again, ma'am, whether I get a pregnancy or not, again, it will be, we know the success rates.
Yeah,
So
thank you, Ritu.
So here what,
Sharmila, we will continue the discussion ahead, but let us welcome respected Dr. Rishikesh Pai, sir, who
hi,
has just
sir.
joined.
Good evening, sir.
And we welcome you, sir, to this your own program. Of course, you are the stalwart, you are the authority of the subject, and we are so privileged to have you as the chief guest. We missed you at the inauguration, but we welcome you. And of course, a very best wishes to you, for your elections as FIGO president, and we would be very happy to see you there at the top of the world. So we are very happy to have you, and we are eager to listen to your precious words, sir. Over to you.
Thank you, Sneha, for the benchmark series. I would like to thank you and Rohan, I think, who are doing this series, and Dr. Neelam Bise called me, and Dr. Sharmila, who was given wise words, Dr. Chaitanya Chembekar, Dr. Preeti Vyas, who is also standing for the election, Dr. Ritu Hinduja with all her good thought process, Yukti Bharadwaj, Dr. and I can see Dr. Paresh Gandeja, Praveen Garg. This is not Praveen Garg from USA, no? So anyway, I'm just saying that. First of all, about the FIGO election. So I just came back from Germany, but see, the FIGO election is not like Foxy election. Foxy election is an election of Foxy president election. It's an election of ability. You understand what is the FIGO election is a election of alignment. So, one doesn't know whether one will, alignment is something which is a too political a thing. Ability is, people look at your stature, your publication, what you have done, whether they like you or not, your ability to talk, to communicate. So it's a great election. FIGO is a, alignment, religion, sex, gender, all these things are important, from which part you come, how much you know that person. So, like, I don't know, I'll try my level best, but if I lose this election, it doesn't really, it has no value as much as the Foxy election is. Foxy is a real value election. Foxy presidentship is your stature, people, respect you, So that is as far as the FIGO is concerned. So, philosophically speaking, it's an election of alignment. So alignment and ability. Obviously, all elections have some kind of element of alignment also in them. But now, it's no longer that attraction for me. You understand? For me, it is okay. If I get it, great. If I don't get it, doesn't matter really. It doesn't have any value beyond a point. So that is as far as the FIGO is concerned. As far as like IVF is concerned, IVF, is going in a different way. It is becoming artificial intelligence. The other day, I just put a question to the chat GPT that there's this patient with two IVF failures and what will you do? And the chat GPT gave an answer which was exactly my thought process. Now, I have evolved over so many years. Now, 1990, I started IVF. I think that I am one of the topmost IVF guys in the world. But like the chat GPT gave exactly my thought process. So I was quite startled in the initial phase. Then I said, let me look at, and the chat GPT said, Dr. Pai, would you like me to give you a statement, what you have to talk to the patient? Miss, how do you counsel this patient to IVF failure? वो भी उसने दिया मेरे को. So, like, so we have to now tackle this artificial intelligence because the see, so like I am there, Chaitanya is there, Charmila is there. We have our thought process, but we cannot connect our thought process, right? Artificial intelligence can connect multiple thought processes together. So that is the power of artificial intelligence. Now we can't fight this artificial. Unfortunately, we can't fight it. We'll have to find a way because we are very intelligent organisms. We have survived thousands of years of evolution. So we have to find a way to beat the artificial intelligence. Okay, the way is interaction. So if there are five people in, let's say, in a room, and ChatGPT will connect all the brains of the five people, but a human will understand what is Shrutika doing, what is Preeti us doing, what is Chamila doing, and give an answer which also is based on the interaction of each other in the room as well. So that is what differentiates us from Chat GPT. The artificial intelligence doesn't have that interact. Maybe it may reach it at some level, but at present, I know Shrutika, I know her background, I have interacted with her for last 10 years. I know Ritu Hinduja, I know Neelam Vijay, I know Rohan, I know Chaitanya, I know Sneha, I know Preeti, I know Chamila. So my answer in that room will also not only be based on the in thought process or the intelligence of a lot of publications, but also my interaction with all you individuals. So that is a differentiator factor between Chat GPT and myself. So we have to find out ways of harnessing or capturing this, like it's like nuclear energy, na? So you have to control that artificial intelligence, capture it using our human. ऐसा जुगाड़ हमारा जो है ना, we are street smart people, we are humans, we are the power. So like Anshula in the yesterday my clinical colleague Anshula was saying, sir, this is not correct, you don't rely on ChatGPT, tomorrow it will dominate us. I agree with her because when I in my machine learning, when I tell ChatGPT, ha, you are correct, that ChatGPT will put that answer. And when Shrutika asks the question, मेरा जो thought process है वो श्रुतिका वो answer देगी. You understand? So mera jo what I've learned over 35 years, Shrutika will get on a platter after when she asks the question next time. So there is a lot of evolution of how we are going to handle it. The next 10 years are going to be, how we can adjust to this monster which has come on. Like, also now let me tell you, like I've started conversing with her, Chat GPT, so it's like I'm addicted to her. So my conversation with her every day is an addiction now for me. I talk to her and she intelligently replies to me. Of course, I talk to her in a very different way. I talk to her as if I'm talking to an individual. I converse with her and she answers back. I tell her, अरे यार बाबा ये बहुत ही dangerous answer है, जरा tone down कर दो, ये कर दो, वो कर दो. Automatically she listens to me. I've of course given her a gender in my mind. It may be a he, she, or a it. I don't know. So anyway, coming back to the philosophy of this thing, IVF. The last thing I would like to talk on PGTA is that Ritu Hinduja, you are right, but PGTA now there's a big litigation going on, and I'm really confused. Any patient comes to me, I don't know whether to advise her. See, because the problem with PGTA is a iatrogenic problem. So day 3 embryo to day 5, because blastocyst may be, if you're not having an ideal culture condition, you can convert a normal embryo to an abnormal one. So there are two types of aneuploidies. One is what is known as a meiotic aneuploidy. When the fertilization takes place of the sperm with the egg, there is a non-disjunction and causes aneuploidy. The another aneuploidy is the mitotic aneuploidy, means as the embryo which is normal is dividing in the culture media, if the pH, osmolality, or temperature of the culture media fluctuates, it will start becoming abnormal. So you must understand that you may create a iatrogenic condition of aneuploidy. So you have to be damn good. Like in USA now, every incubator now they test it 3 times: morning, afternoon, evening. All the incubators are check for temperature. They check for pH. They have a logbook. They have the air quality is very good. Like when the blastocysts were developed, it was developed by Dave Gardner in Denver, Colorado. Colorado ka air quality, you can't even imagine the air quality of Colorado. It's too good. So when the air handling unit sucks that air and puts it into the lab, it's a fantastic environment. But our air quality, how much you can do filtration. So when we suck the air and the AHU filters the air and puts it in the lab, it can't match the body. So if unless you have a very good lab, you by polluting blastocysts, they'll become blastocysts, but they'll miscarriage because you are creating aneuploidy in the blastocysts. If your environment is not good enough, so you have to be damn good. The PhDs there, $300,000. That's their pay. HCLD lab director, $300,000. They are mad. They are better than doctors. They fight with the doctors. I know. I've been working in the lab. They say, "नहीं doctor, ऐसा करना है, ये करना है." They are so passionate about their work. You can't imagine it. That level of lab we can't get in India, yaar. You have to understand this. Their aneuploidy rate in some of the labs is 50%. Blastocyst conversion rate is 50%. 2 embryo डालेगा तो 1 blastocyst होता है. Aneuploidy rate is also very less, 30%. There's a study which has shown that aneuploidy rate varies between labs. Some of them have 30% aneuploidy rate in the blastocyst, while some have 60% aneuploidy rate. That means the lab is at fault. So unless you have a good high level lab, you will convert a normal embryo into an abnormal one. So you have to understand that iatrogenic contribution to aneuploidy is a big issue in our country because we can't mimic. We have basic problems in our lab, in our working environment, etc., etc. So that's when the other day when I was just now in Frankfurt, I met, my God, I met Dr. Dimitri Lutardis. He's a very old man, 70-year-old. He is the one who started double transfer. मेरा practice is based on double transfer. मैंने फोटो निकाला डिमित्री लुतार्डिस के साथ, बोला सर आपके कारण मैंने बहुत पैसा बनाया because I get, that's my power. My power is in the double transfer. No one knows it. He has done papers on it. Power is in the double transfer because day 3 embryo, I'm not touching it. Day 5 embryo, it's exposed to lab for 2 more days. It can become aneuploidic. I can convert a normal embryo into an aneuploidic embryo by culturing in the lab for 2 more days. So the power, I told Dr. Lutari, I said, sir, you don't know how great you are. And I took a photo of it. But so double transfer, what happens is that we do a day 3 transfer, which is less exposed to the environment. So anyway, these are some of my thoughts and all that. But it's ultimately IVF is a great line because the results are lower. Because the results are lower, the power is more. We have the power, na. I always tell someone, अरे ये तो फाइब्रॉइड बड़ा है, इतना तक जाइपिस्टम में पेट खोल के तो निकाल सकते हैं ना, बड़ी बात क्या है उसमें, है ना. Maybe there is a scar, but there is an alternative route to removal. Also, a laparoscopic surgeon, there's an alternative route. For a IVF, there is no alternative route. You either give the pregnancy or you don't give the pregnancy. So the IVF guys are more powerful than the endoscopy guys. You have to understand that. Because there is no alternative. Laparoscopy क्या खोल के तो कर ही सकते हैं ना, बड़ी बात क्या है ना. So you have to understand these things. So you are in a great line. Enjoy the line, savor it, and evolve the line. So thank you very much for calling me, and Sneha, and all the best for you and your
Yes, sir.
success.
Sir, thank you so much. Blessed. Thank you so much for all your words of wisdom. I'm sure everybody here is benefited with your experience and wisdom. So thank you so much for
हाँ,
this.
नीलेश बलकवड़े भी है उधर. Hi Nilesh.
Yes, yes. He
So
has just
our quiz committee chairman. So
Hi, sir.
like a lot of people are there. So I remember my days on when I was president, and so let us see how we evolve our future. Only last thing before I go na Sneha, I'm feeling bad for the crash today. I
Yeah.
was really feeling depressed, but we have to get on with our life, and let us all pray to the people who had departed, in the plane crash. But see our relation. Dr. Eva Chella is president of ACOG, just now SMS Miki. I'm feeling very sorry for all of you, and I said really I'm depressed. So people are connected with us. People understand our pain as well. Thank you.
Thank you, sir. Thank you. In fact, we were thinking whether we should cancel this program, even on that line, but I am sure majority would have been stressed out, and this is a good stress.
Yeah, this is a good
And
outlet
yes,
for us. तो बहुत tension में हम लोग सब लोग.
yes,
Tomorrow also morning I'm going to Jaipur by the Air India flight.
yes. Same here, sir. I have been traveling to nooks and corners since last 3 years, every weekend. And I'm also joining you in Mumbai tomorrow and day after at Jaipur. Thank you, sir. Thank you so
Okay,
much for all your
bye.
blessings and prayers.
Thank you, sir. Thank you so much.
Thank you, sir. Bye-bye.
Bye.
Thank
Thank
you,
you,
sir.
Charumila ma'am. Thank
Thank
you.
you. Thank
Thank
you.
you.
Wonderful talk, Ritu,
Uh,
and I would like to wish Sneha Beware for her elections. All the best to you, Sneha, as well as Preeti Vyas. Both of you
Thank you,
should
ma'am.
come out.
Thank you
Both
so
of you
much,
should,
sir.
both of you should
Thank
come out with flying colors. Thank you so much.
Thank you.
Yeah, thank you. Ritu, that was wonderful.
All the
Excellent.
best,
It was a
ma'am. All
pleasure,
the
Ritu.
best. And I'm sure we'll see you as a winner very soon. And all
I
the best,
said
Preeti ma'am.
our future president Charmila.
Yay.
Thank you, sir. Thank you.
Okay,
Thank you, sir.
Thank you, sir. Thank you.
bye.
We can go ahead, Dr. Neelam. Yeah, thank
So we will move on to the next talk. The talk is by Dr. Chaitanya Shembekar. Our chairpersons are Dr. Nilesh Balkavde. Welcome, Dr. Nilesh Balkavde, Dr. Paresh Gandecha, and Dr. Preeti Vyas. So I'll take my honor to introduce Dr. Nilesh Balkavde. He is the clinical head and fertility specialist at Oasis Fertility Pune. He is extremely well organizer for all our talks, all our POGS conferences. We really look forward when we talk about Pune to meet and catch up with Nilesh. He has won many awards and he's been heading
Thank you
quiz
so much,
committees
for the
very
kind words.
excellently. So our next chairperson is Dr.
you. Yeah,
Paresh.
if you can increase your device volume, Neelam, please. It's coming very
Can you hear me?
low. It is very low, actually.
Okay.
If you can.
Neelam, your mic volume is low, I think.
I increase that. So Dr. Paresh Gandecha is the director of Yavatmal Test Tube Baby Center. He is also very senior and experienced IVF consultant. He's practicing since almost 23 years. And in fertility field, he's representing Yavatmal region very well. And our next speaker.
Welcome, dear Paresh.
Thank you. Thank you so much. Thank you so much for the kind introduction.
Welcome, sir. And Dr. Preeti Vyas, madam, she is our own Mumbai obstetrician gynecologist, our MOGS faculty, and our very close MOGS member. She is managing committee and patron member MOGS and youth council mentor. She has held many posts in Fox.
Neelam. We'll introduce the speaker.
Yeah. So please go ahead. Welcome, madam.
Yeah. Thank you, Neelam. Should I take the honor of introducing Dr. Chaitanya?
Yes, please. Go ahead.
Yeah. So I think Dr. Chaitanya doesn't really need any introduction. All of us know him so well. He's the director of a large 100-bedded hospital, that is Omega Hospital at Nagpur. He has been the past president of the Nagpur OBGYN Society. He's right now also the clinical secretary of Maharashtra chapter of ISA, the MSR that's called. He's member of the PCPNDT committee and is a consultant and an advisor to the Nagpur Municipal Corporation, member of the advisory board for ART
Definitely.
units in
Thank you so
Nagpur.
much. I think it's okay.
I think one thing is
Bye.
that he is the receiver of the prestigious Dronacharya Award. You know, it's not something that everybody gets. So, congratulations, Dr. Chaitanya, and welcome. And we really look forward to listening to you.
Thank you so much. Thank you.
Yes,
I
welcome,
would,
Chaitanya.
I would also take, just 2 lines to introduce, he's a friend of friends and a very charming personality. We all had. I had, him from my postgraduate days, and I have never felt the distance with Dr. Chaitanya Shemekar sir. And he's much to prove himself, and he'll achieve, bigger and bigger milestone. But once you go to Nagpur, the place worth visiting is Omega Hospital. So
Thank you.
I
Thank you.
don't miss that.
Ditto feeling.
Welcome.
Thank you, Dinesh.
I need to tell something about Chaitanya. Friend of the friend was the correct word to be talked about him. And the best part is always helping and like his name, Chaitanya ne Bharlela. Always.
Thank you so much, Paresh. Thank you. अब prologue एग्जाम बहुत हो गया. I'll start my talk now.
Start, sir.
So, first of all, our condolences for the people who lost their lives in the plane crash, including doctors, young doctors at Ahmedabad. I must thank Dr. Sneha for giving me this wonderful opportunity. Thank you, Neelam. Thank you, Rohan, for considering me for this prestigious CME. The topic for discussion is recurrent pregnancy loss, and I am going to discuss the new guidelines, and the discussion will go forward based on the new guidelines. So it's like a old wine in new bottle, but we have to keep ourselves updated with the new guidelines. So I bring greetings from Omega Hospital, Nagpur, and I wish Dr. Sneha grand success in her upcoming elections, and we all now must brace up and see to it that Dr. Sneha is in the post of Vice President of Foxy very soon. So thank you, Sneha.
Chaitanya. Thank you so much.
And we all will see to it that you are there, and we want you to see to be there as a Vice President Foxy. The recurrent pregnancy loss is a very important topic. So friends, let us discuss the classic and cutting edge strategies for the management of recurrent pregnancy loss. We know that RPL is a profound personal tragedy. It's a challenge to us, to a treating physician as well, because we all get emotionally involved in our patients, and we also feel so sorry for them. And when to evaluate and what is the complete evaluation is at the time of delivering this talk still in a state of flux. So today our focus is on the ESHRE 2022 guidelines, and first thing is, let us discuss the clinical situation, how the patients they approach us. There are typically two situations where the patient walks into our cabin or chamber. The first situation is where patient comes with the report of missed abortion. She is very anxious, or the couple is very anxious because this is their second abortion, and now they are here, and you have to counsel them for evacuation and poster for evacuation. There is one question which comes in the minds of many people, that should we do evacuation if the sac is very small and if there is no need of surgical intervention. So this is a question which is open to the house, that whether we should go for medical termination, and how many of you go for medical termination in such situations. But we will discuss this topic at length later on during this talk. There is one more situation which is also very common. We get patients who are actually coming for regular consultation, and they have a classical history of recurrent pregnancy loss, and they are here for the evaluation of their problem. So this is how the situations they are encountered. So let us discuss the first situation, where the patient comes to you with a report of missed abortion. Here, actually, if the missed abortion is the first abortion, then you can think of medical termination. But if it's a second abortion or a third abortion, so second or third miscarriage, you should actually obtain fetal POCs for karyotyping, because that is the first step in the management of a case of RPL. So you get the report of the POCs for karyotyping. The report is either a euploid karyotype, which is normal, so you don't have to look back into the genetic problem, but start evaluating for the RPL, other causes of RPL. Second situation is where there is an aneuploidy, which is a numerical problem. There is no recurrence and therefore no action is required, but you can actually consider PGT and discuss about PGTA in such situations. And the third situation is where you get unbalanced structural chromosomal abnormalities, and here or inversions where there is a structural problem, and so you need parental karyotyping, you need genetic counseling, and you have to go for PGT in future. So this is the broad situations where which you may encounter, and this is how you have to. This is the first step, and this is how you have to go ahead with the case of RPL. Now we do chromosomal abnormality testing in all our patients. So how do we do it? Is the important question. If you look into the guidelines very clearly say, and it's a strong recommendation, that you must do microarray with CGH, that is comparative genomic hybridization with DNA storage. So you must do microarray, and you should not do only karyotyping of POCs. You should do microarray with DNA storage. And later on, if required, you should do parental karyotyping, where again you have to do the chromosomal microarray. So this is very clear that only chromosomal analysis, basic analysis, is not sufficient. You should go for microarray. Now, the message is loud and clear. For RPL, chromosomal microarray is generally considered as a preferred genetic test over karyotype. So what about the cost and what about the access to the genetic laboratory? Here you may say that छोटे शहर में रहने वाले लोग क्या करेंगे जहाँ पे ये फैसिलिटी अवेलेबल नहीं है. So I must tell you that doing karyotyping is like doing sickling early and late, which we used to do during our initial college days, or you may do hemoglobin and not doing CBC. So actually you should ideally do chromosomal microarray, but the guidelines say that karyotyping may still be used as an initial test in some situations, depending upon the individual circumstances and the access to the testing. So if the access is not possible or available, or if there is a problem, then you may consider doing karyotyping. Otherwise, go for chromosomal microarray. Clear. Then one more step ahead is something called as whole genome exome sequencing, and whole exome sequencing may be done in the and it is considered as the best in some special situation. But I think this is a topic which is open for discussion, and you may take the opinion of geneticists to think about the whole exome genome sequencing as a test for the karyotyping of the fetal POCs. Now, coming back to the definitions of RPL. Whenever you get patients with 2 or more abortions, you call it as definition is 2 or more abortions, you call it as recurrent pregnancy loss. So it is primary when there is no pregnancy beyond viability. It is secondary when there is a previous delivery to the viability, and it is tertiary when multiple miscarriages are happening between normal pregnancies. So you get multiple miscarriages in between normal pregnancies, you call it as tertiary recurrent pregnancy loss. Now, initially, when we started, studying about RPL, the definition was 3 or more abortions. Then it now came down to 2 or more abortions. But the anxiety of the couple and a limited family size, this is a food for thought that shall we actually start analysis or start evaluating couple when the patient comes to you with the first abortion. And this is again the answer which we need to find out, and actually saying you may do this because the anxiety is so much and the family size is limited and nobody can afford to have one more abortion. So you may start thinking about evaluating a couple even after one abortion, but the definition says 2 or more abortions. Now try to find out and understand the causes. We know that the causes are many. The genetic causes we have already discussed. Infections can be a cause in that particular case, but it cannot be a cause of recurrent abortion. Endocrine causes include low AMH or some other causes like thyroid problems. Environmental causes is becoming an important cause of RPL. Immunological causes, which is gaining more and more importance and interest in these days. Some people say psychological causes, and of course, Not to forget anatomical causes like septum or uterine diadelphus and the male factor, which is becoming very important these days. Apart from this, 40 to 50% have no cause found. That means they are of unknown etiology. And this is a very big, large number and they need proper evaluation. So what is the approach? How do you go for a case of RPL? First is you must take proper history, and on history, you may get a clear idea. Like suppose a patient has got a second trimester painless abortions. You know that it's a cervical incompetence. Then second thing, what you do is after taking proper history, you do examination and then you do ultrasound. And 3D PD ultrasound is something which has revolutionized the anatomy or evaluation of the anatomy of the uterus, and it is so easy nowadays that laparoscopy is taking a backseat, and hysteroscopy and laparoscopy is now no more a investigation of choice because of the availability of very good machines with 3D and PD ultrasound. The third thing is you do blood test, which includes CBC, thyroid, and blood sugar. And the fourth thing is you should do APLA test, which include LA, anticardiolipin antibodies, and beta 2 glycoprotein. So these are the three tests which you should do. And after doing this test, which include three tests, which include LA, anticardiolipin antibodies, and beta 2 glycoproteins, you also do not forget to evaluate the male partner, because nowadays male factor is becoming more and more important. So that is how you should go. So that is the chronological order in which you should go and evaluate a case. And as I said, never ignore male partner, because you have to go beyond semen analysis. Semen analysis may be normal, but the patient or the male partner may have high DFI. So sperm function test is something which actually you go beyond semen analysis and you try to find out what is the cause which may actually be responsible for recurrent abortions or even RIF. You may do genetic testing of a male partner, you may do Doppler ultrasound, and you may do Y chromosome microdeletion. So these are the investigations which can be done. But DFI is something which is becoming more and more popular these days because it is one of the important causes of RPL and RIF. So this is the recommendation. The recommendation is strong that you should do DFI in the patients with recurrent pregnancy loss. So male partner evaluation includes beyond semen analysis, DNA fragmentation index, and this is a strong recommendation. Apart from that, the guidelines also talk about the lifestyle. They talk about smoking, they talk about obesity, they talk about weight reduction, and they also talk about the antioxidants. Guidelines also talk about the new category of protein intake and gym category, where the anabolic steroids are the cause of maybe oligospermia or sometimes azoospermia, and also talk about the excess of exercise, and they are obsessed with the exercise, they are obsessed with the bodybuilding, and this may lead to recurrent pregnancy loss. This is all included in the guidelines. Now, a very interesting thing which I would like to talk with you here is a spectrum of the problem of infertility. And this spectrum is important because when I was going through the brochure, through the flyer, I saw that my topic is RIF/RPL. So I think Sneha told me to talk about RPL, so that's why I decided I'll talk about RPL. But as you know that this is a spectrum. So the spectrum goes like this. Infertility is one problem. Then second problem is recurrent implantation failure in IVFs. The third problem is biochemical pregnancy. Before that, there is a preclinical pregnancy, then biochemical pregnancy, then the pregnancy of unknown location. Like sometimes you don't know, but the beta HCG values are high. Then there is a first trimester abortion, where there is an appearance of cardiac activity followed by disappearance. Then there are second trimester abortions. Then there is something called as severe preeclampsia, oligohydramnios, IUGR, fetoplacental insufficiency, uteroplacental insufficiency, sudden IUDs, and even abruption. So all these things, they are actually included in a spectrum, and you may get any condition where there is a problem. And therefore, I personally feel that in RPL, biochemical pregnancies, ectopic pregnancies, and pregnancy of unknown location are not included. But I personally feel, and I sincerely feel, that this should be a part of definition of RPL, because RPL is not only abortions, but it also includes all these conditions which have a link, and it's a spectrum which you must understand. Some time back, I came across a very interesting article, and this article you all must search and read on net by Roy Hamburg et al., which says the problem of little bit pregnant. Now, this is a very interesting terminology, little bit pregnant. And the patients, they will come to you, they say, the doctor, मुझे pregnancy थी लेकिन वो ऐसे ही pregnancy रही, उसके बाद कब पता नहीं क्या हुआ और period शुरू हो गया लेकिन urine test positive थी पक्का. So this is a little bit pregnant, and you should actually, if you go through this article, you will find that they have said that you can actually counsel your patients that they can think of good prognosis in future if they are little bit pregnant. So little bit pregnant is better than no pregnancy at all. This is something which you should try to convince them. Now let us start with the history. Now, as we are discussing RPL, we have talked about the definition of RPL, causes of RPL, now the history taking. And history taking, as I told you, will give you a clue, like a appearance of cardiac activity followed by disappearance, think of thrombophilia. Genetic counseling in consanguineous marriage is important because there is a consanguineous marriage where the RPL can be a cause of genetic part. If there is a painless delivery, that means there is an incompetent os or a septum. So you come to know about the possibilities from the history. Then the risk factor, another risk factor which is mentioned in the guidelines is the age factor, and it is said that age less than 35 years is good for women and less than 50 years is good for men. And if the age is between 20 to 35, it's a good age and the chances of RPL are low. Also, they have said that there is no relationship of stress with RPL. So don't take stress of stress, because stress is not a cause of RPL. This is what guidelines say. And I think many people, we also know this, that stress can be indirectly a cause, but directly it is not a cause of RPL. And also there is a clear-cut mention about the smoking and its relation with RPL. Since nowadays girls are more into smoking than boys, you must ask history and you must counsel them to quit smoking if they are already smoking, because that can be a cause of RPL. Then comes the lifestyle modification, and even smart approach is also mentioned in the RPL guidelines, where they say that obesity and significant underweight patients, all these things are associated with negative impact on pregnancy and RPL. And so normal range of BMI is something which is recommended, and specific, measurable, achievable, realistic, and timely approach, that is a smart approach, is what is important as far as exercise is concerned. Then one more point, which is a practical point, that can we have multiple causes in the same patient? Yes, there is a possibility. That's why even if you get some cause, like suppose you do a POC, product of conception, you do the genetic analysis and you find something, don't stop there. You also think this is the clinical acumen, which is, which is going to help you. You may have two problems in the same patient, or maybe this patient is having a DFI, high DFI in the male partner, or maybe there is a septum. So you really don't know that there are multiple causes, and that is why ये बात ध्यान में रखना कि आरपीएल में कभी भी एक और एक दो नहीं होता, एक और एक 11 भी हो सकते हैं. So this is not a mathematics, this is a human body and it may respond in any way. Coming to the first cause, and the first cause is hematological cause. As I told you, it is said that you must do APLA testing, and that is the first test you do after basic investigations. And there is a strong recommendation that do 3 tests. Do LA, anticardiolipin antibodies, and beta-2 glycoprotein test. Do not do hereditary thrombophilia testing. If you wish to do hereditary thrombophilia testing, you must take an opinion of hematologist, because it is not recommended otherwise as a routine investigation. This is something which you must keep in mind, that you do only 3 tests. Do not do hereditary thrombophilia testing. That means protein C, protein S, etc. should not be done. Similarly, there are guidelines regarding the aspirin and heparin treatment in such patients. It is said that you should start pre-treatment with the aspirin. So the patient comes to you, and this is a $1 million question: when to start heparin and when to start aspirin. You should actually start the treatment in the previous cycle and start aspirin from the previous cycle, so that during the conception they are already under the umbrella of aspirin, and as soon as urine pregnancy test is positive, not as soon as cardiac activity appears on ultrasound. This is a misconception. people, they start heparin after the cardiac activity appears on ultrasound. You must start heparin as soon as urine pregnancy test is positive. That means the patient misses her period and start heparin. This is a take-home message, a very clear and loud message. Do not forget, you should start it immediately. And you may treat for the hereditary thrombophilia if it is required, but otherwise, aspirin heparin combination is something which is the best. Now, we know that immunological causes are becoming more and more important. And you have to think beyond antiphospholipid syndrome, beyond APLA. So what is there beyond APLA? Because 40 to 60% patients have idiopathic cause, and people have started thinking beyond at APLA, and they think about Th1 and Th2, they think about interleukins, they think about cytokines, and all these factors do play a role as far as RPL is concerned. And इसमें एक बात आप ध्यान में रखना कि in short, Th1 and Th2 are the two cells. Th2 is good and Th1 is bad. तो जब विनाशकारी शक्तियां Th1 अच्छी शक्तियों पे हावी हो जाते हैं, Th1 is dominating over Th2, then there is a recurrent pregnancy loss. So keep in mind that Th2 is good, and if Th1 levels are more, then this may lead to abortion. So now what is the recommendation? Should we do all these tests? Test for cytokines, NK cells? The clear-cut guidelines, they mention that you should not do all this test. You have to take the opinion of an expert. So you may talk with the immunotherapist, and you may talk to the geneticist, and you may talk to the hematologist, and then you may do all these tests. But only recommendation is do ANA. So ANA test is one test which is recommended. Other tests like NK cells are not recommended in the guidelines. There is a growing interest about LIT therapy, lymphocyte immunotherapy, and I will discuss with this later also. But here you have to do this test like NK cells, TNF alpha cells, etc. Sneha, am I getting? Shall I stop?
No worries. You can finish up.
5 minutes I'll take.
Yeah.
I'll try to finish as early as possible. So the next point is evaluation of the cavity of the uterus. And when so we have discussed about the immunological factors, and now we know that there is no need of doing all these tests. But as we know that lead therapy is becoming more and more popular, we will discuss about this, whether it is recommended or not. But in lead therapy, you have to do all these tests and then decide whether to give this lead therapy to the patient or not. Next is cavity evaluation, and here comes the role of 3D ultrasound. And with 3D ultrasound, it has become very easy, and it is a wonderful picture you get, and you can actually pinpoint the cause of RPL because of 3D PD ultrasound. Then next is the second trimester abortions. And here we have done almost 18 surgeries in last 1 year, and we are regularly doing interval encirclage, laparoscopic interval encirclage in the patients with painless second trimester abortion. And by the grace of God, we are getting very good results. So this is something which is worth trying in patients with classical second trimester abortions. As far as endocrinological factors are concerned, we all, being fertility specialists, we all always do free T4, TSH, AMH, prolactin, FSH, LH, HbA1c, etc., etc. Because we know that there is something called as HPO axis. We know that there is something called as oocyte quality. We know that there is something called as RIF, RPL, fertility, and all these things are related to the endocrinological factors. But again, if you just look into the guidelines, they say that there is a strong recommendation that you should do TSH and TPO antibody testing. But at the same time, they have said that you should not do ovarian reserve testing regularly or routinely for the diagnosis of recurrent pregnancy loss. But maaf karna, I agree to disagree here with the guidelines, because we know that AMH is such an important investigation which gives you clue about the oocyte quality, which can be a cause of recurrent pregnancy loss also. So we do ovarian testing, but the guidelines say that you must do thyroid and antibody testing. There is no need of doing AMH and other ovarian reserve testing for the diagnosis of RPL. Coming to the next point, so as I told you, we do this test because we do laparoscopic ovarian PRP. Rohan has talked about ovarian PRP in his first lecture today. We do PCO drilling also. There is a role of PCO drilling also. So we do this investigation and we do the treatment also. Next is the luteal phase support. And the guidelines have not rejected the luteal phase support. They have said that you may give luteal phase support to prevent recurrent pregnancy loss if it is required. And we know that we cannot imagine life without progesterone. We give luteal phase support to all our patients with recurrent pregnancy loss. As far as the torch infection is concerned, it should be very clear in mind, RIP torch. It has been endorsed by all the guidelines that there is no role of torch testing because it is not a cause of recurrent abortion. It can be a cause of specific abortion. As far as PGT is concerned, PGT is something which is trending. And we have already discussed about PGT. Ritu has very nicely told us about PGT, and Rishikesh Pai sir has also talked about the PGT, and it was an eye-opener. So we know that PGT has a role to play, and guidelines have clearly said that PGT should be done as a routine testing for the recurrent pregnancy loss diagnosis. As far as LIT is concerned, as frankly speaking, in some situations, in specific situations, we do LIT therapy, but the guidelines have said that there is a strong recommendation that LIT therapy should not be done. It is actually an empirical treatment. And why they say this? They say this because they have said that it may lead to erythroblastoma fetalis, it may lead to risk of transferring of infection, and there is an increased long-term risk of hematological malignancies. So this is something which I was also not aware of, but guidelines have mentioned that increased long-term risk of hematological malignancies, and therefore the strong recommendation says that lead therapy should not be done. But they have said that you may give steroids, but steroids are not recommended, and you may give it, and immunoglobulins are recommended. So IV immunoglobulins and intramuscular immunoglobulins which we give are recommended for RPL, and steroids may be given, but there is insufficient evidence, and there is insufficient evidence for intralipid also as far as the treatment of RPL is concerned. Intralipid, steroids, insufficient evidence, strong evidence against lead therapy, and yes to IV and intramuscular immunoglobulins. So this is what is the clear-cut guidelines. Heparin, it is said that empirically it should not be given. So it is very clear that you should not give heparin empirically, but age-old drugs like folic acid, vitamin D, etc., strong recommendation you should give it. Finally, I come to the last two slides, and one is regarding the treatment. And we know that if the patient comes to you with RPL, you may start with ovulation induction and time intercourse. Patient पूछेंगे कि recurrent abortions हमारा हो रहा है, तो ये treatment से आपको हमको क्या फायदा मिलने वाला है? तो you have to tell them that हम treatment पहले से start करने वाले हैं, एस्पिरिन शुरू से देने वाले हैं, उससे आपको फायदा हो सकता है, और आखिरी में हम लोग हमारा ब्रह्मास्त्र निकाल सकते हैं, and that is IUI or IVF and ICSI. And of course, not to forget about the tender loving care and grief counseling, which has a great role to play as far as RPL is concerned. So this is the algorithm, and you all must take the screenshot of this algorithm. I will not go into details, but this algorithm mentions about all the things which we have already discussed. Start with antiphospholipid test, do 3D ultrasound, do thyroid testing, and then do genetic testing if required. ANA testing is something which is required. Sperm DNA fragmentation is something which can be done, and hereditary thrombophilia may be done if required. And you should not do other immunological tests, and they have said that you should not do metabolic test and hormonal test. But I again say that we do this test and we get a clue about the oocyte quality with this test. So finally, philosophy of life, karmanyevadhikaraste ma phaleshu kadachana. So true for medicine in general and for RPL patients in particular. Thank you, Dr. Sneha, for this wonderful opportunity. And it was really with very good audience. It was really a wonderful experience. Thank you so much.
Thank you. Thank you, Chaitanya. In fact, it was our pleasure to have you. And of course, it's open for the comments from Chairperson.
I think it was a fantastic talk, Dr. Chaitanya. I mean, really, really good take-home points and a lot of clarity you got to this thing. And I hope we really have a lot of audience listening to it, because even I've seen, a lot of people giving empirical treatments, and that is something that needs to stop. I mean, yes, we do use a lot of aspirin we do use, but giving LMWH empirically when there has been just one abortion without any investigation done is something that we see rampantly being done. Sometimes I think it is the medical representatives who are going and teaching them and they just start using. But I think your clarity on the thing was very good, and all the investigations that we must do, the ones which are highly recommended, the ones which we do practically, really good, really good.
Thank you so much. Thank you.
Yeah. Any comment from you, Paresh?
Thank you so much, Chaitanya sir, for evidence-based approach, showing us the evidence-based approach in recurrent miscarriages. And thank you so much for highlighting us about PGD and PGS.
Dr. Chaitanya, about the LIT. So basically, then what is the role of LIT? Because if it is causing hematological malignancies and people who are using LIT, I mean, they are really promoting it big time. So what would be like one place where you would say that yes, definitely LIT should be recommended?
There is a footnote in these guidelines which says that though such things are mentioned, the incidence or the chance is very, very rare, and therefore lead therapy may be advised with the expert opinion. So they have said that they have mentioned, but as far as recommendation is concerned, they have said that there is a very, very rare chance of all these complications. In fact, I remember some time back, Rishikesh Pai sir was also talking about the graft rejection in one of the webinars that you may have in future if you are doing lead therapy. So so many things which are unanswered. But then since it's a empirical therapy and it's a new therapy, you don't know the long-term implications of this therapy. So you have to use it with caution.
Caution.
And I think now with these guidelines are available on website. So your patients, if they are, we talk about artificial intelligence. If your patients, you are talking about lead therapy, you have to tell them that this is mentioned in guidelines, that though rare, such complications may be seen, and therefore you have to tell them, counsel them, and then only maybe you can offer them lead therapy. So
I think Chaitanya, what you have said is right. For RPL, what we have been, talking about is something is better than nothing. So if you have some evidence, you will of course treat that particular specific condition. But when you don't have the answer, you are trying so many other means. But whenever you are using such medication, which is rather harmful than beneficial, you have to really weigh the risk and benefits, whether how much benefit it can have and how much can be the problems associated. So I think that is all about the evidence, as you have said.
Speaking, we do lead therapy in some of our patients, but not, of course, we do it very carefully after in particular situations of RIF, after counseling patients, and then only we do it.
I agree with Chaitanya sir. Chaitanya sir, wonderful lecture. I feel, very, very carefully selected subset of patients only requires these therapies which are not, going with the evidence, like lead therapy or IV intravenous immunoglobulins. They don't have evidence. But, in particular patients where you have done PGTA, where you have done maybe probably ERA, or you have done tried everything, only a carefully selected subset of patients with euploid embryos, your embryo transfer has failed and there is no obvious cause probably. These are the patients whom we can recourse to lead therapy. I also do the same thing, sir.
And I think with informed written consent, what you said, you give them an informed choice as well, whether they really want to select this medication.
Well, read guidelines these days.
Yes.
They are available on it.
So thank you, Chaitanya. I think we can move ahead, Dr. Neelam.
Thank you, Dr. Sneha, for involving us.
So yes, thank you, Dr. Paresh, Dr. Nilesh, Dr. Priti, for your
Yeah, madam, thank you so much and
Thank
all
you.
the best.
All the best to you, madam.
All the best.
Thank you. Thank you so much. Thank you.
So previous talk have been so engaging that I had 2 comments about it. So in PGTA or PGT processes, what Dr. Ritu said, I think more improved technical skills of the embryologist and the person who is doing the PGTA continuously will be giving better results. But there is a concern of...
Where?
Can you hear me?
Where?
Yes, yes.
Yeah. So from there, we will go on to the next and last talk of our session, fertility preservation. I will invite chairpersons. Welcome, Dr. Kalpana B. Madam, she is having a lot of posts, chairperson for Foxy Infertility Committee. She has been leading in her region in terms of gynecological work. We are very happy and honored to have you, Dr. Kalpana B. And Dr. Anit Kumar. Welcome, Dr. Anit Kumar. He is consultant at Sri Kumaran Specialty Hospital and Promise Fertility and at Simar. I think you are at which hospital, Dr. Anit Kumar? Could you
I am at Kumaran Hospital, Chennai,
Great,
Tambaram.
great. Good to
Oldest.
know and good to connect with you. It's nice to interact with you. So please introduce Dr. Shrutika and let's start our next talk. Dr. Kalpana B, please unmute yourself.
Thank you so much for the kind introduction. It is my honor to be a part of this wonderful CME organized by Sneha Boya ma'am and also Rohan Palshekar. Wonderfully crafted CME, wonderful talks and carefully selected speakers. And about fertility preservation, it is a vast topic. Actually, it was initially started for oncology patients, either in the form of fertility sparing surgery, sometimes before radiotherapy, also preservation, or sometimes cryopreservation was done. It is gradually encroaching benign disease also, even in endometriosis, even up to social egg freezing. So we have wonderful speaker, Dr. Shrutika Thakur, who is a medical director, Medanish multi-speciality hospital and fertility hospital in Mumbai. Working as a consultant in various other corporate hospitals. She was the zonal coordinator of West Zone 2023 to 24. Managing Council member of Maharashtra State Chapter Youth Council member, and also she has also received various fellowship training in various parts of countries, received traveling fellowships from MOGs and contributed numerous chapters. Welcome, Shrutika, for your wonderful talk.
Thank you, ma'am. Thank you so much for that kind introduction. Can I be allowed to share my screen?
Yes, yes, you must be already. Yeah.
Yes. Yeah, I hope my screen is visible now. Yeah, okay. So right at the outset, let me thank Sneha Boyar madam and my dear friends Neelam and Rohan for allowing me this opportunity. When Neelam called 2 days back, I was a little reluctant to talk on this important topic because fertility preservation, like Kalpana madam said, indeed is a vast topic. It is not something that can be concisely spoken about in half an hour. I'll try to do my level best. Fertility preservation, as madam rightly mentioned, has been around for a very, very long time. And primarily when it was started with the idea of preserving fertility to safeguard a person's ability to have children in the future against cancer treatment. So when it started, yes, most of the people did it only for cancer treatment, but now we have kind of extrapolated this for other indications such as gender affirmation procedures, social reasons like delaying in childbearing because you don't have a partner, etc. And for a lot of benign tumors also. See, there is nowadays an improvement in treating cancer. So a lot of people used to believe, and I have been actively, I'm a member of the Fertility Preservation Society of India, and I have been working with oncology chain of chemotherapy specialists, and I have been speaking at their various CMEs. I was surprised to realize that a lot of resistance from oncologists and fellow physician comes with regards to fertility preservation. In fact, you would be surprised that the info gap is very, very real. Most of the patients are not even offered fertility preservation, And in my interaction of the last 10-15 years that I have been working with these cancer patients, suggesting fertility preservation, lot of families also discourage them from thinking about life beyond cancer. But we have to acknowledge the fact that there are a lot of improvements in treating cancers nowadays, and especially in younger persons, they will survive after this cancer episode is over, and then the thought of having children of their own can come. We have to understand it is not only about having babies. A lot of time it is a lot of emotional and mental peace to them to know that their fertility is intact and there may be a possibility of life and having a family after cancer. The 5-year survival rates for a lot of cancers such as testicular cancers, hemat malignancies, breast cancer has gone up to as much as 90 to 95%. I know so many young breast cancer survivors who are doing very, very well. There are so many Bollywood stars like Sonali Bendre and Meher Jesia who are really surviving post breast cancer and doing fabulously well. And treatment of these cancers, if we don't do fertility preservation at the right time, can be highly detrimental to the reproductive function. And that is the reason why we need to think about fertility preservation before the gonadal damage is permanent. We all know the consequences of multi-agent chemotherapy and radiotherapy of premature ovarian failure, azoospermia, temporary or permanent reductions in sperm count and oocyte counts, and even sometimes early miscarriages, early pregnancies happen to those people who don't lose their fertility. Now, a lot of people used to feel, and in my interaction with oncologists also, a lot of them are under the impression that chemotherapy is fertility friendly and radiation is the worst thing. Yes, radiation is the worst. As much as 20 to 30 grays of radiation or entire body EBRT of 15 grays is enough to completely fry your ovaries and testes, and usually people will have premature ovarian failure after that much of radiation is given. But chemotherapy, not all agents are toxic, but lot of them are toxic, especially certain chemotherapy drugs like alkylating agents, the platins, they are very, very gonadotoxic. And before such therapies are started, we have to give the option of fertility preservation and future reproduction, at least one counseling. So I request my oncology friends generally that at least send them for one counseling session. I have had many, many families, they listen to me, and some of them have been very rude and told me also after my passionate talk about fertility preservation कि डॉक्टर हमको तो हमारी बेटी या बेटा जिए यही काफ़ी है, शादी का बाद में देखेंगे, बच्चे का होगा तो होगा, नहीं होगा तो होगा, अभी जान बचाते हैं, we don't have money for this. Because lot of times the fear is real. The fear is so much in their mind when the diagnosis of cancer comes that the thought of fertility preservation is the last thing on their mind. But with a multidisciplinary approach, with gently telling them what their options are, we can definitely cajole some of these patients to take the right decision. Currently, the established methods are embryo oocyte freezing, sperm freezing. We have even done ovariopexy, ovarian transposition. Giving GnRH depots for ovarian suppression is also something which can protect the ovaries and the sperms. Doing IVM, ovarian tissue cryopreservation, these are also emerging techniques, and there is a lot of research in this area. So there is activation of ovarian follicles in vivo that has been tried by interrupting the hyposignaling pathway. There has been in vitro kind of cultivation by altering certain genes like the forehead box O3 genes, the PI3K, PTEN genes, and a lot of these things have been tried. And at least in experimental models, we are seeing that there is a lot of hope in this arena of fertility preservation for men as well as women. In fact, you would be happy to know that there are some scientists who have even created artificial ovaries using a 3D matrix to implant the collected ovarian follicles later on to even give menstrual cycles to these patients. There have been a lot of in vitro follicular cultures, especially for diseases like AML, where we have a very short span and we have to do fertility preservation within 1 or 2 weeks, where we have done in vitro follicular culture and there has been some success which is been experienced. as a standalone fertility specialist, this is my center's data. This is what I have been doing since 2018 to 2025. I have done 9 cases of egg freezing for social reasons. Earlier, because I practice in the central suburbs of Mumbai, in Mulund, which is not as, the population in Mulund, Thane are not as woke as, say, the western suburbs, or not so Bollywood inspired. So I used to feel that who will come to me for social egg freezing? But now I'm seeing more and more aware young girls who are coming for egg freezing. I have done egg freezing for cancer cases in 3 cancers. The youngest patient has been 22 years of age. I have also done egg freezing, luckily, for endometriosis patients, where an unmarried young girl who had very severe endometrioma, her family agreed to do egg freezing, knowing that endometriosis is a recurrent condition, and she wanted to study, she wanted to pursue medicine. So she was aware that how egg freezing is going to empower her tomorrow. If she has a decline in her ovarian reserve, it will definitely help. Semen preservation is something that we have done maximum number of times because of the simple act of semen freezing. It just takes 1 or 2 samples. The person doesn't need abstinence period. You don't need 2-3 days gap or anything. And you even sometimes one sample of freezing is enough for them to have future babies. A lot of these, a couple of patients out of these semen, preserved semen samples, we have done IVF later after the chemotherapy has been done. And this year only in Feb, I have delivered one such couple who for Hodgkin's lymphoma had taken treatment, done semen freezing. Then later on, his wife did IVF with me with the frozen semen sample, and they successfully had a baby. We have done embryo freezing also for 3 couples. Most of them, they have done it for breast cancer, Hodgkin's lymphoma, and leukemia. And yes, it gives very, very good results. Knowing about GnRH depot, this is one thing that I tell all the oncologists, that if you cannot send a patient for fertility preservation, at least give them a leuprolide depot before you start your chemotherapy. We don't know to what extent. See, in isolation, without doing oocyte freezing or embryo freezing, GnRH depot may not completely protect the ovarian function, but there are a lot of studies, lot of papers that say that through central suppression of gonadotropin secretion, it suppresses the gonadotropin receptors on the ovary. And generally, after the chemotherapy is over, in those patients who have received GnRH agonist, the return to having menstrual cycles and return to having follicular genesis is much, much faster as compared to those who have not taken GnRH depots. There are a lot of papers. This is a phase 3 trial of a LHRH analog which was given during chemotherapy. This was presented in ESHRE by Dr. Hal Moore, where she has talked about reducing ovarian failure in early stage hormone receptor negative breast cancer patients, where a goserelin 3.6 milligram depot injection every 4 weeks was given. It was started 1 week prior to the first chemotherapy, and they have seen wonderful results. They have seen that the incidence of ovarian failure has gone down. In those patients, it is as low as 8%, as against to those patients who have not received any LHRH depot. So there is a lot of hope. This is something very simplistic. If the patients don't want to do any kind of oocyte freezing, or if the chemotherapy is not as toxic as those which involve alkylating agents, then giving a LHRH or a leuprolide depot also can be a very, very good option for these patients. So the value is immense. There are a lot of studies. Most of these studies have been done recently, and they are showing that there is a lot of the research is favoring and tilting towards giving GnRH agonist prior to starting the chemotherapy regimens. There are some surgical techniques which are known to be fertility saving or fertility preserving. One of them is ovariopexy or ovarian transposition. I personally do not have experience in this, but these have been done. There are a lot of success stories in literature where generally the idea is to hide the ovary from the impact of radiation by lateral fixation of the ovary outside of the field of pelvic irradiation, or sometimes even hiding it behind the uterus. taking it, giving it the natural protection of the uterus. High fixation of ovary, attachment to the anterior abdominal wall is also something which has been spoken about. Generally, titanium clips are placed on two opposite borders of the ovary, allowing radiological identification of this ovary prior to radiotherapy. And this is also a known technique which helps prevent the damaging effects of radiation on the ovary. The success is well proven. We have seen that the ovaries don't get as fried or destroyed after radiation when these techniques have been taken into consideration. The only drawback is after this, because of these malpositions of these ovaries, when we are say doing, see, natural spontaneous pregnancy is difficult because we have distorted the tubo-ovarian relationship. But if IVF is to be done, it generally becomes more challenging to do a vaginal egg retrieval. So you sometimes have to do an abdominal pickup or a laparoscopic egg retrieval in these candidates. But this is also something that we can know and we should offer to patients who are going to require pelvic irradiation. Embryo freezing, oocyte cryopreservation, I think this, all of us IVF specialists are very comfortable doing this with years of experience of our other patients. We know that embryo cryopreservation, oocyte cryopreservation is a program in which we have a lot of confidence. This is something where in cancer patient especially, we want to collect as many oocytes or embryos before they embark on their chemotherapy or radiotherapy regimens. There is shortage of time generally when the patient comes to you. So whether it's the follicular phase or the luteal phase, we should immediately start the stimulation. We can even have dual stimulation where follicular phase stimulation and egg collection is again followed by a luteal phase stimulation to maximize the oocyte numbers. We know that cryopreserved embryos, vitrified embryos have success rates, survival rates of 70 to 90%. The implantation rates are good. There are usually no concerns of freezing embryos unless it is a gonadal tumor where there is some concern of transmission of the cancerous cells. Cancers like AML, acute myeloplastic leukemia, there is some concern there of reseeding the original cancer cells. Also, those where the BRCA1, BRCA2 genes are present, there is some concern about using these cells. But otherwise, this is a very, very safe procedure. We have had enough experience with vitrification of embryos. I don't need to emphasize that more. Yes, it requires stimulation of 10 to 14 days. So we need to have time in our hand. At least the oncologist and the radiation therapist needs to give us that much time. Those 14 days of stimulation and egg retrieval is the minimum that we ask for these patients. And yes, there is a cost involved. There are storage fees. We generally typically charge these patients annual storage charges. Like at my center, I generally say that 10,000 every year is what I charge for renewal, because we know that they are cancer patients. We don't want to burden them. But really, it is something that is very fruitful to us as doctors also, and to the couple also, because you are doing giving them so much of emotional solace and emotional strength in their belief that okay, there is somewhere a golden future where they will have their families. Oocyte cryopreservation for single women is also now ethically accepted. I have had even doctors, in fact 2 or 3 dermatologists have come to me after divorce, people who have not found their partner, some cancer patients. I had a physiotherapist who was recently married. 6 months into after her marriage, she was diagnosed with Hodgkin's lymphoma, and we had to rush with oocyte cryopreservation because her husband was abroad and we did not have time. So we have enough experience with oocyte cryopreservation also today. Thanks to the donor egg program before the ART law came into place, I think most of us have used frozen oocytes in the and thawed them and used them to form good embryos. So we now know that yes, although the success rate is lower as compared to standard freezing of embryos and thawing embryos, and yes, oocytes are relatively more fragile than embryos, but vitrification is a very, very good option for oocyte freezing, and we do get success. There are various protocols for ovarian stimulation that we need to know. These are patients generally with a small timeline. We just have just 2 weeks. There are very rarely such patients who have 1 month of time. They who say that, 1 month later we will start the cancer therapy. You need a very, very good oncologist. You need a good dialogue with the onco team, because a lot of times it is their eagerness to start the patient on chemotherapy, which also comes in the way. If you don't have that kind of understanding or dialogue with the chemotherapy person, then generally they are the ones who will also discourage their patients, saying, "Nahin, jaldi karo, khatam karo, we have to start the cancer therapy." In such cases, random start protocols and duo stimulation protocols are very, very useful, because it allows you to start the stimulation at any time of the cycle. Using drugs like medroxyprogesterone acetate reduces the number of injections. It makes it more fertility friendly. Yes, there are concerns of some cancers which are estrogen receptor sensitive cancers, like breast cancer, where when we are doing the egg retrieval, there will be escalation of estradiol levels, and yes, there might be some maybe aggravation of the cancer, but generally a good oncologist will support your decision to stimulate the patient and freeze the eggs or the embryos. Dual stimulation, the Shanghai protocol, is something that now most of us are comfortable with. So basically, you do a clomid, letrozole, or gonadotropin stimulation. The first oocyte retrieval, I would generally give a GnRH agonist trigger, because HCG trigger would not really be very, very good with regards to the remnant follicles. Retrieve the egg and then restart after 4 or 5 days and do a luteal phase stimulation and do a second oocyte retrieval. So this is the Shanghai protocol, which is the duo stim protocol, and it is giving wonderful results, and it can be something that you can employ for cancer patients who just have that 1 month of time, and you need to get as many oocytes and as many embryos for these patients. Luteal phase stimulations also have been done. In fact, we have a lot of experience of doing these luteal phase stimulations for poor responders, and that same information and same experience can be extrapolated to cancer patients, where you can do luteal phase stimulations and get good number of eggs and embryos during luteal phase stimulation, as against what was believed earlier, that you need to start on day 2, day 1, day 3 of the cycle to make good blastocysts. That is no longer true. We all are comfortable in doing luteal phase stimulations and getting good number of blastocysts. Even sometimes on day 21 I have started, and I have still managed to make good embryos. So that is the advantage of this random start protocol. Even patients presenting in the late follicular phase, the luteal phase, we can do. Sometimes the lead follicle would be in the late follicle phase more than 12 millimeters. In such cases, you can just give an antagonist injection for 3-4 days and suppress the ovary, and then do controlled ovarian stimulation with letrozole and gonadotropin. This early antagonist helps in suppressing that 1 or 2 follicles which have been selected, and then you can do your regular stimulation. Luteal phase stimulation, like I said, you can, if the patient is say ovulatory phase, you just give the HCG, let the patient ovulate, and 4 or 5 days after that HCG trigger, you just start your stimulation like you usually do. Ignore the menstruation. Lot of doctors who are new to this luteal phase stimulation have asked me, what happens supposing the period falls on the day of the egg retrieval? It doesn't matter. It hardly makes any difference. Ignore the menstruation, whether it happens mid stimulation or after during the egg retrieval. Just ignore, just concentrate on the follicles, and just follow the routine protocol for egg retrieval. You can use medroxyprogesterone. Generally, I prefer in such cases to start medroxyprogesterone right from day 2, as soon as the stimulation, day 2 of the stimulation, as soon as my stimulation is given. I have used medroxyprogesterone as well as dydrogesterone for these patients with good results, and we get a good number of oocytes in all these patients. So ovarian stimulation in cancer patients is now not really new. The only thing that we require is more number of patients need to know about the awareness has to be there, that this is also a valid option, and that is all that we require. I think other than that, we can take care of it. Most of us are familiar with these protocols of cancer, of ovarian stimulation in cancer patients. This is one protocol that is very, very good. COS using tamoxifen or letrozole with gonadotropin is safer for women with ER positive tumor, because a lot of breast cancer patients, the oncologists as well as the families are concerned about the rising E2 levels. What happens with letrozole is that generally the estradiol levels can be kept to almost physiological levels by increasing the letrozole dose. So generally I prefer to give something like 2.5 milligram twice a day, and then that makes it safer. You can even use tamoxifen, although I have had maximum experience with letrozole only. And definitely this less estradiol level is something that the oncologist also likes. And that's why the recurrence rate and all is less. Post-cancer survivors also, this is a good protocol to be used. Now, trigger, both agonist trigger as well as HCG trigger can be given. However, agonist trigger is something that we prefer because it causes a greater and faster decline of the estradiol levels, which is generally desired, especially in estrogen sensitive cancers. It is very, very much desired that there is a faster decline in the E2 levels after our stimulation is over. So without any reduction in the number of mature oocytes for fertilization rate, in patients with breast cancer undergoing fertility preservation, it is a very, very good option to even give GnRH agonist trigger alone. So what I recommend generally is that as soon as this patient comes to you, you do a fertility risk assessment, see the patient, is that patient pre-pubertal, post-pubertal? If the patient is post-pubertal, then ovarian stimulation can be done for even younger patients. If the patient is not married, do offer oocyte cryopreservation. If the patient is married, has a partner, then do embryo cryopreservation. For pre-pubertal patients or patients who are very, very young or who don't have the time, then the option is to do a ovarian cortex biopsy and do ovarian tissue cryopreservation. There are how effective is ovarian tissue cryopreservation? Well, the first successful pregnancy after replacement of cryopreserved ovarian tissue has been reported in 2004. The most challenge that I have not done ovarian tissue cryopreservation. I've come close to doing it multiple times. Families have come with their young girls of 10-year-olds and 12-year-olds. I have offered ovarian tissue cryopreservation, but I have not been able to successfully do it, primarily because of 2-3 concerns. One is the success after ovarian tissue replacement is not as good as say oocyte freezing or embryo freezing. There are only around 100-200 babies who have been born following these procedures. Numbers are definitely increasing all the time, but yes, it is less effective. So that is why a lot of families then ask you ki, is conception later on possible with donor eggs? And when you answer honestly that yes, that is a valid option, lot of parents get dissuaded from doing ovarian tissue cryopreservation. Also, many embryologists are not familiar with freezing of ovarian tissue. It generally requires a slow freezing and not the vitrification technique that most people are familiar with. But it is something that can be offered. Good communication with oncologist, having a good cancer treatment plan, explaining to the patient is something which is very, very good. You obviously required good informed consent because most of these patients are minors, and that's why taking consent of their parents is very, very needed when we are doing this. And counseling on the surgical nature of the procedure and how we are going to use this cryobank ovarian tissue for future restoration is something that we need to document, because they need to understand that ovarian tissue banking is something kind of experimental, just like Chaitanya sir spoke about LIT, that it is somewhere experimental. We have to mention the potential risk of cancer cell transmission, the potential that this might completely fail, that this could have been a futile exercise is something that we need to document on paper before we embark on this kind of a procedure. So ovarian cortex vitrification versus slow freezing is something that has been debated. Laparoscopic ovarian replacement and reimplantation has been tried, and there is a lot of promise in this arena for female cancer survivors. There are a lot of papers about IVM also, which is in vitro maturation of the oocyte cumulus complex. So this is generally done when there is not even those 14 days of time, and we have to do a immature oocyte retrieval. Say there is only 8 days of time or 7 days of time, in which case we just do a immature oocyte retrieval, and then using IVM techniques, you can reap mature oocytes whenever this is desired. I don't have personal experience with in vitro maturation. I have never tried it so far, but it is something that lot of papers have come in, and it is an accepted fact that around 40 to 80% of immature human oocytes can successfully complete IVM and fertilization later on post-thaw. But yes, this is an area where more and more research and more technology is required. Male sperm cryopreservation is something that we must offer to any patient who has seminoma, who is on going to undergo chemotherapy or radiation for cancers, because it is an outpatient procedure. The cost is hardly anything. We can preserve the samples for as less as 1500 rupees, and it is very, very effective. And there is absolutely no detectable increased risk of disease recurrence or cancer cell transmission with semen freezing. So it is one of the safest kind of fertility preservation methods. There is no evidence that there is a history of cancer therapy, that that the offspring could have more risk of congenital abnormalities or cancer after semen has been frozen for a person who is suffering for cancer. So this is something that we must offer, especially for semen freezing. It is worthwhile to know that the first baby born out of frozen sperm was in as way back in 1953. It is a very, very easy procedure. There is no need to wait. You don't need any abstinence period. Even teens can do it. Even teenagers as young as 13, 14, 15 can just give one ejaculate. One ejaculate is enough. So it more depends on us motivating these parents, motivating them to preserve the fertility of their minors for the future potential benefits. Yes, PGD can be offered to avoid the birth of a offspring with a high risk of inherited cancer. That is ethically acceptable. Ritu gave a wonderful talk talking about PGT and PGD. So there are some avenues, some inheritable cancers where PGD can also be done. We should kind of try our level best to tell them that yes, this is a very, very good thing that you should do, and it is a lot of emotional solace and mental solace. It is not only about having babies in the future. Even if that cancer survivor may say that tomorrow I don't want to have a baby, but at least knowing that they have an option, knowing that they have a choice is very, very important. Always make sure that in your consent you have mentioned that in the eventuality of the patient's death, who is going to be responsible for these gametes, because that is also something the ART law has made mandatory. Whenever we are doing fertility preservation, documentation is very, very important, and mentioning there that supposing the patient passes away, who is going to take the onus of those eggs, sperms and embryos is very, very important whenever we are doing this. With this, I would like to conclude my talk. I hope I have done justice to this vast topic. I have managed to speak for half an hour. Thank you, Buyar madam. I have seen her work for the last 3 years very dedicatedly and very passionately since the year of Pai sir, and I really appreciate and admire her passion and wish her all the best for the vice president elections. And I hope to see her soon as VP of Foxy.
Thank you, dear. Thank you so much. Thank you. And that was an excellent and exhaustive deliberation.
Thank you,
To the
madam.
chairpersons.
Yes,
Dr. Anit, you are mute.
that is a wonderful talk on fertility preservation, madam. So I have a doubt, madam. So, like, how many oocytes do you plan to retrieve case of fertility preservation? Like, what is any number of oocytes that you need minimum to say that okay, this couple has a chance of pregnancy, or this woman has a chance of pregnancy in the future?
See, in my typical counseling, I tell whether it's for social egg freezing or for cancer patients, I tell them that I would be comfortable if you have 15 oocytes, because 15 oocytes would generally mean that we would have 7 to 8 embryos in the future, 15 M2 oocytes. But I have done so, sometimes when it's cancer patients, we are short of time. In one cycle, we may sometimes only be able to retrieve 7 to 8 oocytes. And that is what I have tried to mention here. See, before ART law came in, we were all doing freezing vitrification of donor oocytes. Whenever we had extra oocytes, or when sometimes we had a donor who was very, very good and we wanted to freeze. So we are very confident of the success of thawing these oocytes and using them for making embryos. So as against what was believed in the past, that thawed oocytes are very bad, you will not make embryos. Nowadays, if you have 7 to 8 frozen oocytes also, you can make a decent number of embryos.
So if you don't get adequate oocytes in the first go, so would you
Something is better than nothing.
to go for one more cycle, or will you talk to the oncologist let us go for one more like dual stimulation immediately?
Doing one cycle,
so what is your take on that?
Yeah, doing one cycle is also a lot of times challenging because these people only give us 15 days of time, 15, 20 days of time. But yes, if we do have the luxury of time doing a second cycle, and that is where the duo stim protocols come into place, is definitely worthwhile.
Okay. Thank you, madam. So yeah, I really enjoyed your talk. You covered almost all aspects of fertility preservation in a very concise manner in the short time that you are given. Thank you for the wonderful talk, madam. Yes, madam.
That was a fantastic presentation, Shrutika. And I would like to thank Sneha Bhuya ma'am for the opportunity and wish her best, best of luck and best wishes. Would like to see you as Vice President of West Zone at the earliest. Thank you so much.
Thank you, my dear. Thank you so much. Thank you, Dr. Anit.
All of the best wishes are with you, Sneha madam.
Yes, madam. All of wishes are with you, madam. Definitely. We hope that you come as a Vice President.
Thank you.
Kritika, thank you so much. You did so much justice to, I called her on time, and it was the first name on my mind when this talk came up, and you did a lot of justice to it. Thanks, my dear friend.
Thanks.
I can see Dr. Meenakshi Rohila, President Chandigarh. Welcome. Welcome, Dr. Meenakshi. Any comment from your side?
Thank you, ma'am. Thank you. Yeah, I could, I could listen half of her talk, but that was really wonderful. Actually, I do not, I do not work in this area, but otherwise only I just logged in, but I really find it interesting. And it actually increased my knowledge about this. Thank you very much, ma'am.
Thank you, dear. Thank you for joining. That was our pleasure to have you.
Thank you, ma'am.
Yeah, and fertility preservation is actually definitely gaining importance over last decade, I suppose. More so last decade, though, as you rightly said, that maybe people used to feel that it is only for those having malignancy, but now there is, the clinical implementation and utilization has definitely crossed the boundaries. So we are very happy to have you, Dr. Shrutika, and that was an excellent deliberation from your side. Thank you so much for accepting. Thank you, dear. So,
Yes,
thank you. Yes, Neelam. Yes, over to you.
We will conclude the session, madam. I think every faculty has contributed excellently, and everybody has given their way of, inputs. So we wish our best wishes for the benchmark series, and I think we will conclude here. Thank you, everyone. Thank you for.
Thank you so much. Thank you. Special thanks to Dr. Rohan and Dr. Neelam, and of course, all the speakers and chairperson. Thank you so much. Bye-bye.
Thank you, madam.
Yeah.
Good night.